I know we'll do ladies and gentlemen, we're going to be starting in just a moment. If I can ask all the legislators to please take your seats.
Turn on my light when you start it. Senators, we need to get started, please. Take your seats. Thank you, everyone, for being here. I'm Senator Pam Vidal, and today the Senate Finance Committee and the House Health Committee are holding a joint hearing in the joint hearing room. And we'll have two briefings. We're going to start with the briefing on the AHEAD model implementation and emergency department wait times. As many of you know, the AHEAD model is a new federal program that we are working on implementing in Maryland this year. So, Chair Bagnall, would you like to say a few words?
Thank you very much, Madam Chair. It is a pleasure to join you and the Finance Committee as we always work hand in hand together. As many of you know, this has been an ongoing challenge with the AHEAD model and with addressing our ER wait times. So we look forward to hearing about the progress that has been made. I am going to ask for our members to adhere to the committee rules that we have, which is one question, one answer, not one question, one answer from every panelist. I will defer to the Chair of Finance as to how your members coordinate their questions as well.
Chair Bagnall, my senators typically don't have more than one question, so we'll see how today goes. Thank you very much. Should I call him up? Oh. Okay, so thank you very much, Chair Bagnall. I would like to ask Secretary Mina Sessionami to come to the table, and John Crom, Executive Director of the HSCRC. And I believe you have a presentation for us. And Michael Huber from the Governor's Office are going to be joining. Thank you.
Chair Vidal, Chair Bagnall, for the record, my name is Michael Huber. I serve as a Deputy Chief of Staff in Governor Moore's office, and I want to thank you for the opportunity to address your committees today. I'm really glad to be here in my somewhat still new role to speak to you about our approach on AHEAD and what it means for the future of healthcare in the state of Maryland. And I'd like to start by giving immense credit to Secretary Sessionami and Executive Director Crum for negotiating a strong state agreement and securing 100% participation for Maryland's hospitals. This allows Maryland to maintain what makes it unique, a status that I know this body is rightly proud of. And it wasn't easy. When the Trump administration took office, many people told the administration that the Maryland model was doomed, and the feds began the negotiation process with stipulations that would have destabilized the model and send the state's healthcare system into chaos. But through partnership with many of you in this room and a steadfast commitment to our values, we have delivered real wins for the state of Maryland. But it's not enough to focus on the agreement for its own sake or for the model for its own sake. The real questions are around what we're going to do with it and how it benefits Marylanders, how it benefits your constituents. In other words, how will this agreement help us achieve our shared goals of improving patient experiences and outcomes in our facilities, increasing access to care, making healthcare more affordable, and investing in prevention and public health to drive down costs? And none of this does any good if our hospitals and our carriers and our patients are struggling. That only exacerbates access to care challenges, ED wait times, and other dynamics that this body has led good work to address. It's with these questions in mind that Governor Moore has stressed the importance of pulling together the various departments, regulatory entities, and other components of state government to point the way forward to do things like stabilize access to quality MA coverage for our seniors, support rural health, bolster primary care, and many other important goals. The Department of Health, HSCRC, but also the Insurance Administration, CHRC, MHCC, and the Health Benefits Exchange all have important roles to play in this work. And crucially, so does this body, and so do so many other stakeholders. We're seeking input, meaning real dialogue, from carriers, from hospitals, and others on what the path forward should look like, and we seek to do so in a collaborative and transparent manner. Chairs, thank you again for the opportunity to present. I'm happy to take any questions that you have.
Thank you, Michael. Who wants to go next? The secretary, are you next?
Yes, great.
Madam
My mic is on. Thank you again, Chair Beidel, Chair Bagnall, Vice Chair Cullison, Vice Chair Hayes, for the opportunity to discuss with all of you the AHEAD model today. I am driving the slides apparently as well. Okay, so I think I will build off of where Michael left off. That really, as we talk about the AHEAD model, as we talk about ED wait times, it's really within the framework overall of what are we all collectively working to achieve for the people of Maryland. And that really is a world-class health system, one that delivers high-quality care to every Marylander, regardless of who they are or where they live. And doing this by improving access to care, increasing affordability, and addressing and eliminating health disparities. And the AHEAD model is a key tool in our collective toolbox to achieve those goals. So a little bit about the AHEAD model. So as you all know, we renegotiated the AHEAD model with the current federal administration. AHEAD now stands for Achieving Healthcare Efficiency Through Accountable Design.
Madam Secretary?
Yes.
Are you supposed to have slides up? You talked about
It
slides.
says on here that it's screen sharing, but
Okay, technologies work. I'm sorry, I didn't want to interrupt, but we didn't have anything to look at, so.
do you want me to pause?
How important is the slide to your presentation?
Well, right now I think it's okay because
And we have paper copies.
Yeah, and I think as we get to more of the data, we should make sure that the slides are
Okay,
available
they're
by
working
then.
on it. Thank you.
Okay. So this model really builds on, as Michael described, the success of the total cost of care model. And we signed as a state the new agreement on November 12th, 2025, that provides the framework for the AHEAD model over the next 10 years. And importantly, this agreement really reflects months of detailed negotiations with strong engagement from hospitals, payers, clinicians, and other partners. And it includes commitments to maintain hospital global budgets and quality metrics across payers, because we know that aligning enables driving change and improvements in a much more effective manner. It sets goals for primary care spending to expand access and strengthen care delivery, again, because we all know how important primary care and prevention are to meeting people where they are and keeping them healthy. And it also enables innovation and system transformation. It increases choice and competition, improves quality, and helps us establish clear health improvement goals and measures. So with this AHEAD model, again, the decisions that we have before us really will have system-wide impacts across the continuum, and it really requires thoughtful, coordinated, and a comprehensive look at all of the interconnected aspects of our healthcare system. And that is why, as Michael alluded to, under the governor's direction, the Maryland Department of Health has convened a multi-agency regulatory working group, bringing together regulatory agencies, including the Maryland Department of Health, the HSCRC, the MHCC, MIA, Maryland Health Benefit Exchange, because again, all of these pieces are very interconnected. But perhaps even more importantly, a key part of what this regulatory working group must do is really engage the stakeholders, engage the community, engage the patients, engage the hospitals, the payers, the businesses, so that we can get input from the ground. We can get data, we can get ideas, we can get perspectives as we are all working together towards the collective goals of affordability, access, and quality. So to that end, as we were leading up to this state agreement, we really tried to establish a foundation of that deep partnership and engagement that we could carry with us moving forward. And I will say that it was really important to have everyone working together to be able to land an agreement that works for everybody in the state. So there were monthly HSCRC commission meetings, total cost of care model meetings, and then also there was a leadership group that met regularly among stakeholders to think strategically about our engagement, alongside a technical work group. And we additionally held office hours. Our phones were always open. We had many ad hoc meetings together to be able to, again, get the information and share information needed so that we could make sure that the direction we were moving was one that could work for everybody in the state and to achieve our common goals. So I think I'll turn it over to Executive Director Crom from here.
Thank you so much, Chair Beidel, Chair Bagnall. Thank you so much for the invitation. For the record, I'm John Crom, the Executive Director of the HSCRC. I'm going to get into a few of the details of what we were able to negotiate and enter into, because this is now plan year one of the AHEAD model, right? 2026 is year one of the AHEAD model. So first, just to give you a sense for the overall term of the model itself, it is a 10-year performance period, right? So again, we're in year one. It's a 10-year performance period. After that period, there is a transition period of up to 60 months beyond that, right? At that point, we'll really have to have kind of figured out what are the post-model options for the state and for the federal government. That's what's going to bound kind of the parameters of that transition period. You know, as the Secretary mentioned, you know, we were able to sign that state agreement, you know, that was restated after the initial state agreement that we signed under the Biden administration. And we signed that last year in November. And then with the hospital partners, they all signed their participation agreements at the end of 2025. If we can go to the next slide. I think really what I'd like to do here is highlight a couple of the major kind of changes and tentpole characteristics of the and obligations of the AHEAD agreement. So the first thing I would say here is that there are some changes coming for hospital global budgets within the AHEAD model. So for year one, so 2026 and 2027, largely things will stay the same, right? The state will set all payer global budgets, but then in years 3 through 10, the state will set the portion of the global budgets outside of Medicare fee-for-service, but CMMI will be running a rule set that governs the global budgets for Medicare fee-for-service. Another aspect of this that's going to be critical is that it requires us to set an all-payer total cost of care target. That did not exist under the total cost of care model, but that is work that is just launching now with that multi-agency work group to really figure out what is the state's approach to monitoring and adhering to a total cost of care target across all payers. We'll continue to implement the Maryland Primary Care Program, which I'll discuss in a moment, but that will be evaluated for 2028 and beyond. And then finally, really critical aspect is that 85% of the in-state all-payer acute care hospital revenue needs to be paid under a global budget methodology. That threshold is lower than what was in the total cost of care model, and it's for a very important reason, right? Carving out some of the high acuity services that are provided within hospitals, those services can't reasonably be prevented in terms of demand for those services on the time frame that we're talking about here, right? And we have to be able to account for things like the cost growth of technology, et cetera, within that kind of sphere of services. So that was a really important point that we were able to negotiate out. And then we will do some work at the HSCRC over the next few months to figure out how we're going to methodologically do that carve out for that 15% of high acuity complex services that hospitals provide. If we can go to the next slide. There are statewide accountability targets that we need to meet in order to participate in the AHEAD model going forward. I will talk about a little bit more in depth about that first one, the Medicare fee-for-service total cost of care target. And frankly, this is really the tentpole accountability target. It's the most important target for the federal government. It was the most kind of hotly negotiated target as we described earlier. Want to spend a moment discussing this because it works a bit differently than under the total cost of care model. So the key thing to note here is that the savings expectation is a percentage off of national Medicare fee-for-service cost growth, okay? So what that means is if you assume, as the federal government did and all of our projections are based off of, if you assume that national cost growth is going to be about 5% over the life of this model, we would need to save about 0.35% off of that by the 7th year of the model, right? So assuming that hospital global budgets are projected to grow by 5% per year, we'd have to be growing at approximately 4.7%, right, by year 7, right? So that is kind of some of the context for that. Compared to the total cost of care model, what we achieved over the last 10 years was a reduction of about an average of about 0.46% off of national trend per year, right? So it's a little bit lower, but again, recognizing that on a go-forward basis, right, it's harder to prevent utilization, it's harder to prevent costs going forward, right? So want to make sure that folks are keeping that in mind and happy to spend more time talking through this, but our projections are based off of that 5% trend assumption, and then the savings expectation is a percentage off of that. There are other statewide accountability targets. I'm sorry, to translate that into dollars though, right? Because that's how we evaluated the total cost of care model, was really on dollars saved off of national, right? Off of national trend. What we're assuming is as the hospital revenue grows from about 24 billion today, let's say, to projected 33 billion by the end of this model, 33.7-ish billion by the end of this model, that savings expectation translates to, in Medicare dollars, about 460 million. And then what we're projecting in total, because Medicaid runs, as it does today, Medicaid runs with the Medicare rates. In total, that translates to about 870 million, right? So I know that this is a fairly complex aspect of the AHEAD model, but it's really critical to put these numbers into context. I'm happy to answer questions, as we go here, and then also to spend time with folks talking through our projections here. We have other statewide accountability targets as well. I mentioned the all-payer total cost of care growth target. We also have a Medicare fee-for-service primary care investment target. Again, that is something that the multi-agency work group will take up, largely led by MHCC. There's also a statewide quality and population health target set. We've talked about that in the past. We'll come back, I'm sure, and talk more about that as we go. But the Maryland Commission on Health Equity is where a lot of that work has been done. So those are the major accountability targets for the AHEAD model. If we can move to the next slide. I mentioned primary care. I'll just quickly mention here, there are 2 new value-based programs that are being established here, or one new from Medicare, Primary Care Ahead, and then one that the state is running. It's launched for Medicaid advanced primary care, and then, as I mentioned before, MDPCP, which has been in the state for a few years now, and is a pretty popular program with a lot of enrollment among primary care practices within Maryland. That is maintained for at least until 2028. We can go to the next slide. So one other set of requirements that I'll flag here for you all, and this is something that we will have to work very closely with the legislature on, is that the federal government is requiring states participating in the AHEAD model to select one essentially policy intervention from each of 2 categories, right? And the options are listed here above. Again, the regulatory working group is going to go through a stakeholder engagement process where we really are looking at each of these options and then working with you all to really identify what is the best option to select here, and are there any legislative changes that would be needed in order to meet that objective in next session, right? So this isn't a this session issue to take up. This is really for next session. And I think, okay, and I'll mention here, so to implement all of this, we have a lot of work teed up. Do you want to discuss this one? Okay.
So as Executive Director Crom mentioned, there is certainly a lot of work ahead for us in implementation of this model. And so Governor Moore issued a directive for the Secretary of the Department of Health, myself, on his behalf, to create a working group of state regulatory agencies. Again, so that we can make sure that we are incorporating input from stakeholders, that we are coordinating across our various agencies because of the interconnected nature of policy decisions. As I mentioned before, the process really is prioritizing stakeholder insight, input, and guidance to the greatest extent possible. We want to make sure that we are promoting market stability, healthcare affordability, access, and quality throughout Maryland. And so there are specific policy targets and timelines for how we're going to achieve those policy milestones in a work plan that was put forward. And the first 2 priority areas we will mention here. So cost shifting and Medicare Advantage stabilization. So this is a policy proposal that came from this multi-agency regulatory work group. The work group had several listening sessions and opportunities for stakeholders to provide input. There was a draft proposal that received comments, and then that led to the proposal that went to the governor. So, Executive Director, I'll turn over you to speak through the details.
Thank you. Yes, so where the group landed, right, was, again, in recognition that the path forward here, we want to ensure that the accountability for the savings target is spread, right, across the state. For cost shift, where we landed was that 87 million per year, approximately, which is roughly half of the savings expectation, right, for the model, would be cost shifted to the commercial market. The HSCRC will do some policy work over the next few months to establish the mechanism by which we would do that. So in other words, how would those adjustments be made to the individual hospital global budgets? That work is underway now, and we'll go through a work group process there, and I'm happy to keep you all updated. But at the top line, the 435 million is what we're anticipating in cost shift. For the Medicare Advantage market stabilization component, again, really looking to identify what is the amount of revenue, right, that is attributable to increased hospital rates that aren't accounted for in the national algorithm, right, for setting Medicare Advantage reimbursement. That led the regulatory work group to land on an approach where, again, we would shift some of those costs to the commercial market, right, in order to stabilize the Medicare Advantage market, again, with some eligibility criteria, though, right? And the key criteria that the work group and many of the stakeholders supported were really a couple-fold, right? First, it is intended for MA plans who have the majority of their membership as Maryland residents. It's very important that these are Maryland dollars, right, that they're going to support Maryland beneficiaries. And then second, some quality standards, right, that these plans have to be 3.5 star plans at least, right? And that's important for two reasons. One, it ensures that these are higher quality plans, right, that providing quality services, as well as financial viability. Higher star plans get more reimbursement from the federal government, right? And then finally, a lot of the value proposition for Marylanders for Medicare Advantage is that it lowers out-of-pocket costs. So we wanted to ensure that this is targeted for MA plans that are offering in 8 of the lowest income counties in the state, right? So really ensuring that that value proposition is concentrated amongst the communities that really need it the most, right?
So I think building off of what Executive Director Crom said, lifting up a level, as we talked about, ultimately we are all trying to have market stability, improve affordability, access, and quality. And so I think these are good examples of some of the dynamics that are at play as we are balancing all of that. Certainly, in terms of market stability, we don't want any one part of the healthcare system to bear all of the change. We want to make sure that we have some of that predictability and stability that enables everyone to be able to move forward. What cost shifting is it enables, when we have a savings target that must be achieved through Medicare, to say that some of that savings in Medicare can be achieved by shifting some of the costs onto the commercial market. I think that then helps that it's not all coming out from hospital revenue, and the counter is that it can lead to increased premiums for individuals in Maryland and for businesses. And so those are some of the dynamics that it was very helpful to have that engagement from all of our stakeholders, where each of them were able to describe what would be the impact that they would see from their particular market, their particular experience, as at the end of the day, we want to maintain affordability for Marylanders and for businesses, and we want to maintain market stability so that care can still be provided. So that's just, one example there. And on the Medicare Advantage side, at the end of the day, we again want to make sure that care remains affordable, that it is accessible, and that it is high quality. And hence, where we are seeing where there is support for Medicare Advantage plans as they are navigating these changes, making sure that it is being directed to plans that are serving Marylanders primarily, and plans that are going to be achieving quality standards and are serving those areas where we know enrollees need to be able to have access. In some of the back and forth here, from the draft to where the final proposal was, we did receive input about, well, if there are plans that are not in certain areas, there needs to be an opportunity to get into those areas, and so plans will be able to submit a waiver to say, here is our plan to be able to get into those areas by 2028. So again, I give those as examples of the back and forth and the thinking and the conversations that have happened along the way that, again, build a foundation for the ongoing work that we all have together moving forward.
Great. So I will flag, I won't go into too much depth here on the HSCRC global budget policy timeline, but I want to flag for this, for all of you, that we are hard pivoting to implementation, right? So with the 2028 shift for the Medicare portion of hospital global budgets to CMMI rules, there's a lot of work that we have in front of us at the HSCRC in order to ready our policies for that moment in time. If you can go to the next slide. So what we've done is we've mapped out and kind of published a plan for the next year of policy work, actually 18 months of policy work, that will really help us both, one, ensure that the Medicare global budgets are being established. So we're working in partnership with CMMI to push them to make sure that they are ready, right, to set those policies, and that our stakeholders here in Maryland have an opportunity to really engage directly with CMMI, with us at the state, to ensure that that work is being done and it's being done fairly. If you can go to the next slide. And then at the same time, we at the HSCRC need to take a look at virtually all of our hospital global budget policies to ensure that there are the interdependencies between the federal policies and our policies are reflected, right, in the work that we do on a go-forward basis. I flagged here some of the things that we'll be looking very closely at. When we think about what will happen on an all-payer level, right, so not just at the Medicare level, we have to factor in what's going to happen with the assessments, right, on hospitals, what's going to happen for quality measures, right, since we'll have deeper alignment with the Medicare quality program, data and reporting, how Medicaid will work is a big area of policy work in front of us. And then care transformation, right? How are we going to continue to drive transformation of the health system within the AHEAD model? If I can. It's there.
And we'd be happy to take questions.
First, thank you, Secretary and Dr. Crom, correct? Thank you both. And Michael, thank you for the input from the governor's office. And all along, you've kept us informed, and I really appreciate it. I've learned a lot this year about ahead in the federal government, but I still have a great deal of concern about Medicare Advantage today. So you're talking about cost shifting, and your document says 28. So what do we do between now and 28 when we had, well, let me ask you, how many Medicare Advantage plans reduced their products or exited counties in 2026? How many did we lose? How many plans?
So I don't have that in front of me, but we can get that to you. But yes, several of the national carriers reduced their, essentially, the number of products that are on the market.
And I've heard a number between 50 and 100,000 seniors in Maryland lost Medicare Advantage. That's as close as I can get to the number. What do you think that number is of who lost?
So I think those are still being tallied, right, as we get, through open enrollment. It's probably a little bit less than that, right? But I think, what I would flag is, there's a high number of Marylanders whose plan closed and then would have to either shop for a new plan, or they would be eligible for,
Basic Medicare.
basic Medicare
Which may or may
plus
not cover the
MedSup.
prescriptions depending on which plan they take.
Correct, yeah. So they'd have some disruption to their Medicare.
So what can we do for Medicare Advantage now? I don't think we can wait till 28. The financial loss is really significant, so I think there's a real urgency to implement a plan now. Do you have any plans for this year for Medicare Advantage?
Go ahead.
I think, Chair Beidel, I really appreciate the issues that you are flagging. I think certainly, as we've mentioned before, maintaining stability and really thinking about the people that we're serving is key as we are grappling with these policies. The regulatory work group certainly was looking at what we do with the AHEAD model as that comes into play. I think we would be happy to work with you as we think about dynamics that are at play, in the current moment as well.
Thank you. Last question about Medicare Advantage. There was a grant that I think the HSCRC funded, the grant in like 20 and 21. Is that a consideration? Can we talk some more about that, please, this year?
There were a couple different configurations over the years. One of them was coming out of hospital rates. Others were coming out of general fund. I think that the challenge with the HSCRC component is that would come out of really hospital revenue. And I think at this moment in time, that's challenging. It would also require some approvals by the federal government, which just take time, and they haven't been as open to doing that.
I appreciate your response. I really would like to work with both of you on finding a way to support Medicare Advantage plans. So thank you very much. I think we have a delegate with a question. Thank you.
Thank you, Madam Chair, and thank you for the courtesy. I'm going to open this up to our members in just one moment, but I just wanted to also acknowledge and thank the department for the work that you've done and for keeping us abreast of that work as you went. Myself, Madam Vice Chair, our now Speaker, our partners in finance, and to all of the multi-state agencies, the multi-agency partners. I am also going to thank everyone who is here for your flexibility as we are learning new technology. This is a beautiful building. This is a beautiful room, but it is also a bit intimidating. So we are learning as we go. To our members, if possible, can you direct your question to the person you would like to answer and to our panel? If you would just decide amongst you who is best suited to answer that question. And with that, I'm going to call on Delegate Kaufman.
Thank you, Madam Chair, and thank you, Chair Beidel. And I'm going to direct my question to whomever would like to answer it. You cannot tell because I'm sitting down, but I have cerebral palsy. and I've spent a ton of time in my life in hospitals. And I think one of the key areas, in addition to the wonderful affordability and accessibility that the Secretary talked about, is attentiveness. And so, because oftentimes you push your call button constantly and no one comes, or the doctor spends all of 1 minute with you. But anyway, my question is, how is this going to, hospitals are understaffed in my judgment, so how is this going to ensure that patients get faster, more responsive care? And are we going to get less money from the feds or more money that will hopefully help with staffing? Thank you.
Yeah, absolutely. I'm happy to take the question. So I think there's a couple aspects to this. One is that it was really critical in the AHEAD negotiations to preserve essentially the enhanced federal rates that we received for public payers, right? And that was a critical objective of the negotiation from the state's perspective, and a really big win for the state. What does that mean? It means that patients who are Medicare beneficiaries or Medicaid members, the reimbursement that the hospital gets for taking care of those patients is enhanced, right? That's really critical because we want to make sure that that staffing and that that kind of investment of the hospital and in patient care is equitable, right? So that was one key aspect of the AHEAD model that is preserved. The other thing I would say is that as we move forward, we still have the ability, right, as a state and at the HSCRC and the multi-agency working group to really think through access and how we're ensuring quality outcomes for the care that we're delivering. So we still have a lot of flexibility at the state level to help further the work that's been done by our hospitals to improve the quality of care over the last few years. So I think that flexibility plus the enhanced funding within the AHEAD model is supportive to the aims that you're looking for.
Delegate Kaufman, would you like a follow-up?
Yes, I would. Thank you. Yes, my question is, I appreciate that, but I would like to, would you be willing offline to meet with me to talk about concrete ways to address the staffing issues? Because you have situations where nurses have 5 or 6 patients and different things like that. So I appreciate the general sentiments, but I hope will you be willing to meet with me so we can talk more specifically about this?
I would be very happy to do that, very happy.
Thank you, Madam Chair.
Thank you. Senator Mounts, do you have a question?
Yeah, thank you, Madam Chair. Just quickly, something was part of I believe it's part of the AHEAD model was this grant for rural hospitals, the rural hospital grant, and that's not included in this presentation anywhere. Do you want to speak to that a little bit? Or could you, I apologize, could you speak to that?
Well, I can, and I would be happy to, Senator Mounts. Thank you for raising it. The Rural Health Transformation Program was from HR 1 that provides across the country $50 billion for states to apply for funding up to 5 years to support rural health transformation. Maryland, in the same theme of what we are talking about here, with how we have really engaged with everyone as we have been negotiating and now implementing the AHEAD model, similarly, we had 6 weeks to be able to put together and submit our proposal for the Rural Health Transformation Program. We had 17 listening sessions. We did a request for information and got, I think, 350 comments. Really engaged everyone in figuring out what are the things that our rural communities really need and how can we leverage funding from the federal government to be able to support. And the proposal that we put forward got funded $168 million in the first year. Per person in rural areas, that's double the average that was given across the country. And the money is being given across 3 buckets. First, bolstering the rural healthcare workforce. Second, investing in healthy food in our local agriculture to make healthy choices affordable and accessible. And third, investing in more accessible healthcare, including through innovations and technologies. So that's the basics of the Rural Health Transformation Program that I think builds upon a lot of the similar themes that we have been talking about here with the AHEAD model.
Thank you. And I was under the understanding that that grant was for capital projects. Am I mistaken in that?
No, this grant is for areas of transformation. And specifically, and we can follow up with you further as well, there were several things that CMS said you cannot spend this money on. So all of the areas that we put forward were areas that were in the realm of what we could apply for funding for.
Okay. Yeah, I would like to follow up and talk about that a little bit. And just a quick follow-up, and I want to take, there's a lot of people with questions, a lot of members with questions. But this is very helpful, but I found the presentation to be, there's a lot of words and there's a lot of descriptions, there's a lot of information. And all the conversations I've had about the AHEAD model, it's been about numbers. Is there any document that you've put together to show how the AHEAD model is going to work financially based off of hard numbers or even projected numbers? Something that's a little more concise and kind of lays out what that plan is. Do you have a document like that, and would it be hard to produce?
Thanks. Yes, we do. So, and Senator, I would flag that it is based on projections, right? Because a lot of the numbers within this are based off of percentages. We've done some of that projection work. We're happy to provide some slides to that.
And when one last is, and when the comment about the insurers and money and how all this works, the comment was made that the rates will go up. Is that implied that insurers should not feel any of the brunt of this? Was that I kind of took it as, well, the rates will go up, so we can't expect insurers to have to deal with any of these issues. What did you mean by that, as far as when you were talking about insurers and then rates will go up? What did you mean by that?
So this also comes to how, with our colleagues with the Maryland Insurance Administration, there are various ways in which there are, like, for example, medical loss ratios, and ways in which the money that comes in through premiums is provided as care. There were analyses that were done jointly, particularly between HSCRC and the Maryland Insurance Administration, to look at if there is this much amount of increase in hospital rates for commercial insurers, what that could mean for changes in premiums, taking into consideration all of that framework that exists. And we can also follow up more particularly with our colleagues from MIA.
Yeah, I guess, would it be safe to say that that comment is saying that, well, we got to be careful about insurers because that could drive rates up? Would that be fair to say with the?
I would say that what we were looking at is, how do we make sure that we are maintaining stability and affordability for people across the entire system?
Senator.
Thank you.
We have a lot more questions. Thank you. Delegate.
Thank you, Madam Chair. Delegate White Holland.
Thank you, Madam Chair, and thank you all for the presentation. My question is directed to whoever is best to answer, but I think in a similar vein, I would like to go back to this cost shifting discussion, and wanted to know how will the HSCRC test the assumption that the cost shifting essentially to consumers is really the only solution moving forward, and how might our healthcare system, we talked about the insurers, but even thinking about our hospitals and their resources, but how can we look at our healthcare system and seeing how it could lessen the burden to consumers given this proposal?
Thank you for the question. I think there's a couple things that I would answer. One is not the HSCRC. One is for the multi-agency working group.
Fair.
One of the commitments within the proposal was that we would continue to monitor this over time, right? So that we can, and this really goes to Senator Moss's question as well. We really need to see what the impact is over time and how that plays out for commercial payers. So absolutely, there's a monitoring, and then we can revisit. At the HSCRC level, one of the things that we're really going to be wrestling with and considering options for is how do you equalize the impact across the different regions of the state, right? Because you can imagine that some hospitals have a higher proportion of Medicaid and Medicare patients and a lower proportion of commercial patients, right? And you want to make sure that the impact is not disproportionate, right, across the state. So that's the work that we'll be undertaking.
Okay. But I'll, just very quick.
Did you have a follow-up?
It was, I do have a follow-up, if I may. And just very quickly, again, who's ever best to answer, because equity was removed from the AHEAD name and replaced with efficiency, I wanted to know how our state, given our work that we have done around health equity, will be maintained and how it will be centered moving forward, just again, giving the work that we've done in this particular area.
I can keep going with that. So two things. One is I do want to note that the mechanism of hospital global budgets and the enhanced federal rates per case are something that we all viewed as really important for health equity, right? So we do want to flag that. But there was a lot of work done in 2024 to think through health equity goals and targets. That work can continue under the Commission on Health Equity and under the quality programs that the department will undertake and the HSCRC will undertake. It just won't be officially part of the AHEAD model, right? So I think the work of the state can continue.
Okay, thank you, Madam Chair.
Senator Gall.
Thank you, Madam Chair. And I guess also this is for whomever can answer the question. So unlike my colleague from the Eastern Shore, I'm more of a words person than a numbers person. But I was looking at your, on page 14 under the cost shift column, and I'm trying to understand, and it says in the very last bullet point, amounts to half the anticipated Medicare fee-for-service and the equivalent impact on Medicare Advantage and Medicaid. So what happens to the other half then? How is that, how and where is that going to get absorbed?
So I can answer that. So there's a couple ways, right? So one is reduced utilization through population health management, population health objectives and initiatives of the state. And that could be within the hospital or outside of the hospital, right? So the savings expectation is on total cost. So if we're reducing the cost to take care of a Marylander per capita, a Maryland Medicare beneficiary, that is how some of those savings can be achieved. The other thing I would note here is that a lot of how the savings have been achieved over the life of the previous decade has been through site of service changes, right? So in other words, hospital service that has been done in a hospital high cost setting shifted out to a lower cost setting for which it's clinically appropriate and high quality care, right? That can continue, but even just maintaining what we've done achieves some of that savings over time as well. So there are multiple layers of savings across the healthcare delivery system that we think can be achieved, but what we're kind of noting here and what I think is appropriate, right, is that, as we go forward, that path is harder, right, because we've done a lot of those site of service shifts. We've done a lot of that, a lot of that work. So we just have to be mindful about, are we striking the right balance as we move forward? Again, this is kind of where we landed in terms of, here at the beginning of the AHEAD model, what is a kind of appropriate amount to shift to commercial payers. But, I think as we move forward, again, lots of monitoring and attention.
Okay, seems like it's gonna be a lot. Thank you. Thank you, Madam Chair.
Thank you very much. I want to acknowledge that our former HGO colleague, Delegate Bandari, has joined us. And with that, Delegate Hutchinson, you had a question.
Thank you, Madam Chair. I think this is for Madam Secretary. And first of all, thank you for taking on this very, very tough job. It doesn't go unnoticed to our committee what you have ahead of you. No pun intended there, I guess. So for my professional healthcare career, forever, Maryland's unique. We're under the waiver system, the all-payer model. Are we no longer unique now? Is this Maryland's the same as the other 49 states, or are we still different and unique? And because of where we're transitioning from, is this a harder lift for us than perhaps other states that are going through this?
So we are the first state in the country to negotiate this new AHEAD model. And importantly, some of what went into the work on the CMS side here was that other states were asking how they could become more like Maryland. And so we are first in negotiating this model. There are other states that CMS is speaking with about being part of the AHEAD model. That does not change the fact that Maryland had this unique model that created this foundation that now perhaps other states will be joining into. I will also say that I think, as all of you know, ultimately healthcare is local, and the importance of the fact that each state is negotiating with CMS because each state comes from a different place, has different communities, different markets, and so I think there will always be that aspect to the work that we do in our state and how the AHEAD model is one piece of the overall work that we are doing towards our goals.
Thank you very much. Thank you, Madam Speaker. Madam.
Senator Reedy.
Thank you, Madam Chair. Thank you all for the presentation. And I know it's a lot to wade through, as my colleague was talking about. I wonder if I could start. I had a couple of questions. First of all, at the beginning of the presentation, you talked about the multi-agency regulatory working group and bringing all the stakeholders together, different state agencies, correct? I was curious, as part of that working group, does that include stakeholders within the working group, or is it more we go out and get info from the stakeholders and bring it in our reports? Is that a better way to, am I saying that correctly? Like, for example, we're going to hear from the Maryland Hospital Association. Are they in the working group, or is it the job of the people in the working group to go get their input? As an example.
I can take that if you like. I understand now your question, Senator. Thank you. This working group is of the agencies who then engage with Maryland Hospital Association and others to be able to get input and have a back and forth dialogue, both through the sessions and through comments, for example, where there was a draft proposal and then comments provided that then get incorporated.
And so each agency that's a part of that might have a different role. For example, the exchange might go talk to the insurance providers, correct? I mean, theoretically, versus the health department may be focused more in getting feedback from other specific stakeholders, probably like the hospital. So is that a fair way to say that?
So I think you raise a really important point in your question, because one of the things that we have to do is actually break down those silos and have the different stakeholders and also the different agencies all coming together and discussing these things, because as we have been talking about, where you make a policy change, it has differential impacts across different aspects of the healthcare system. And so, in part, bringing together this multi-agency working group is to bring together the regulatory agencies and the stakeholders for those discussions.
Okay, and so that's an ongoing working group that will continue throughout implementation and beyond, correct?
That is a working group that there is a work plan that we can provide to you. There are areas that have been identified, the cost shift and the Medicare Advantage being the first two. There are areas that have been identified as part of implementation of the AHEAD model to be covered. And I think this is also where we want to continue to work with all of you to make sure that we are able to have good dialogue, to be able to think through all of the various impacts, and bringing back to some other questions and discussion that has happened here, making sure that there is continual monitoring as well as we move forward, so that we can maintain that agility to be able to adjust and make sure that we are continuing to meet our goals around affordability and access and quality.
I appreciate that answer. My one concern I've had throughout this AHEAD model process is that we not lose, we heard earlier about the patients, and that's the most important thing. But number two, I think it's also the people who are performing the care. And so I think a lot of times in the conversation about health care, it's a huge issue nationally, it's a huge issue here locally. Sometimes we forget about the docs, the nurses, and making sure, and frankly, I mentioned the hospital association, they're important, but making sure the voices of the people working at those hospitals, providing the care, we gotta be sure so I was curious how that all works, and so I appreciate that answer. I do wanna ask about, there's part of the agreement is that the state can adjust hospital global budget amounts during this period. How would that be calculated, or am I, because I know we're limited on time, am I fair in summarizing that you guys are going to be coming out with like a formula and a model for how you calculate that soon?
If it's all right, I will have
That's
my...
all right, no, please.
And I would, I'm happy to come and talk through this.
Yeah, we can talk more offline.
In more
Yeah.
detail, but essentially, the financial policies of the HSCRC are the kind of formulas, right, that establish the global budgets. The complexity here is that in 2028, the federal government will have some of those policies as well, right?
Okay, so they'll have some say over that.
So we have
as well.
alignment to do, right,
Okay.
at the state and federal.
And I'm rushing to cutting you off because I know we've got a lot of questions. I think that there's a lot more that I found interesting. I looked at the recommendations from the federal government, from the Trump administration, about which choice we have to pick of the categories. First of all, I think these are fantastic recommendations. So I salute the federal government for working with us closely on this. We've had a lot of rhetoric about hostility with the federal government. I think this is a great example of there's been great cooperation and working together. Can we do all of this? And I say that sort of jokingly, but do we have to pick? Because there's a lot of great stuff. Some of these are heavier lifts than others, but I mean, as I look at modifying scope of practice, certificate of need requirements for non-hospital settings, but then flipping over new and additional modes of telehealth for Medicaid, prescription drug transparency. So, I mean, some of this we've actually been working on here, but I mean, could you just comment about, can we do all of it?
I think in part, Senator, I would say this is where we look forward to working with all of you, right? I think as Executive Director Crom mentioned, these are decisions that are not for right now. These are decisions for a follow-on legislative session, and I think that gives us good opportunity to work together to figure out what makes sense.
But we don't know which one we're picking yet, is what you're telling.
No, this is something. This
We need to
was the
evaluate.
menu that we can then work through together.
Fair enough. Thank you. Thank you, Madam Chair.
Delegate Shalega.
Thank you, Madam Chair. Thank you all for being here. I, as my colleagues, have some questions about the cost-shifting page and numbers and words. We're debating which we're looking at. But I'd like to know, with one of the bullets, this will increase commercial premiums by approximately 1.8% FY 2032, which is equal to $435 million. How many plans is that? Is it 10 plans? Is it 100? You know, how much is this going to cost, and who are you charging?
And happy to come back potentially with the Maryland Insurance Administration who regulates those plans. But it's many, many more plans than just 10, because what we're talking about here are both the regulated markets, so this is the individual market and small group market, as well as the large group plans, right? The self-insured plans, the municipalities, right? So this is pretty broad-based in nature.
But you don't know, like you didn't say, we're going to charge this number of people this amount. You just picked a 87 million a year tax on commercial policies.
So it's because it's done through a hospital rate adjustment, right? It's not kind of a set amount that's just assessed. It's not an assessment. It's an increase in costs that the plans will kind of bear, right, over time. So,
Which means the people will pay, okay.
Yeah.
So that being said, are you still advocating for a hospital tax, or are you still accepting? I mean, I think every year in the budget, there's a hospital tax that the hospitals pay to the general fund. How does that impact? I mean, if you canceled the hospital tax, you could cancel the tax on commercial premiums.
Are you referring to the Medicaid deficit assessment, Delegate?
In the governor's budget for the last few years, there's been a tax on hospitals, and that tax, I believe, if I'm remembering correctly, I'm not on appropriations, but goes to the general fund.
That's right, it does. I'd have to follow up with you about whether that math would pencil out, because I think the numbers we're talking about here don't quite stack up. So in other words, getting up to that $435 million assessed through rates, I don't think the Medicaid deficit assessment is that high. So I don't know that it would be a trade-off.
Okay, please look at that, because
Yep.
if my memory's correct, it was $100 million hospital tax, and according to your documents, you want $87 million in a premium tax. So, you know, this seems like it would put undue taxes if you're doing both.
It's 87 million, and then it ends up being cumulative. So it's 87 million, and then the next year of the plan, there's an additional 87 million, and then an additional 87 million, stepping up to the 435
So eventually,
to
it'll be a
cover-
$435 million
Can I-
per year tax?
Delegate?
It's not, well, it's not a tax. So this is
Sorry.
handled through the
Delegate?
HSCRC via hospital rates.
I'm going
All
to
right,
ask, for
thank
the
you.
sake of time and for the sake of clarity, that if you can get those numbers and share them with the entire committees, the health and the finance committees, so that we have hard and fast numbers that we're looking at. So we're not trying to address off the cuff, that we've got numbers that we can look at. Thank you.
Senator Ellis.
Thank you, Madam Chair. I want to follow up with a question Chair Biden asked earlier on, and then follow-up questions. So a lot of follow-ups, but only one follow-up for me. So talking about Medicare Advantage. In my district, which is 28 in Charles County, you put in most of those zip codes in the entire Southern Maryland region, and less than a handful of plans come up. What are the criteria for, or guardrails for, these plans? Any oversight? I'm not sure who can best answer that.
For the purpose of this program, the key guardrails are One, that within the H contract or the footprint of the plan, the majority of the plan members are Marylanders, right? Maryland residents, right? So that is an important kind of threshold requirement. The other is that they offer a percentage of their total enrollment within the 8 lowest income counties in the state. And largely that is because, again, the working group really wanted to prioritize that plan availability is focused on seniors with relatively lower incomes because it minimizes their out-of-pocket costs. And then finally, there was a quality threshold that was established, the 3.5 stars. Behind that rating, there's a long list of quality metrics that an MA plan has to hit. That program is a federal program. The federal government really does a lot of the regulation and oversight over the MA plans, not the state. But we did want to make sure that to access these dollars, the plans are hitting that 3.5 star threshold.
Okay. Yeah, so I'm sure my county meet those thresholds, but there are no plans in the county. So Charles County is very interesting. It meets 2 of the criterias where you have disparities, rural and majority black. Mm-hmm. And I know people trying to get their physical schedule this year, and they have to wait till November to get an appointment with their doctors. I think we're not doing a good job as a state to make sure these disparities disappear. The regulators are ignoring the rural and double whammy black areas. And that's my question. I know, sir, you gave a very technical answer, but I don't understand what you just said. So I will not follow up. I'll follow up with you later. I wrote a letter earlier. I didn't get a response yet, but I'm very concerned about that. But in the interest of time, I'll stop right there. Thank you.
Thank you, Senator. Yeah, wait.
Delegate Hill.
Thank you, Madam Chair, and thank you all for the work you've been doing for the last year or more, trying to put these pieces together. I'm also going to sort of follow up on the early questions about cost shifting. I want to make sure I understand that the cost shifting, as you've explained, I guess this will be to you, Executive Crone, is through premium shifts, which go to the payers, meaning the population management, where, correct me if I'm wrong, my understanding is that a lot of the population savings, which are the savings that we've seen under the waiver, point 4, what have you, have mostly been achieved through the low-hanging fruit, and so I'm not quite sure that there are savings left to get there, which is why you said it's a heavier lift. So where else will we be getting those savings, and how does that potentially impact provider reimbursement levels and the sufficiency of providers, whether we're talking about at the physician and practitioner level or the staffing at the hospitals, as Delegate Kaufman asked about? Are you expecting that category of the healthcare system to also carry a significant impact of this cost savings that we're expected to come up with without sacrificing quality?
I'm happy to, yeah. So I think there's a couple components to your question.
Because I only get to ask one.
So walking through a couple of them, right? So that the cost shift mechanism is really done through the mechanic of adjusting the differential in hospital rates, right? So so that isn't really system savings per se. It is it is just a shift to where the costs are borne. In terms of the savings drivers, and again, going to Senator Giles' questions, right? Really, there's a couple categories of savings, and I think, happy to deep dive more into these, right? But really, the goal here and the incentives of the AHEAD model remain to focus on population health and a healthier population being lower cost to treat, right? So I think there's a lot of incentive and a lot of work in front of us as a state to figure out, bolster, support population health initiatives that result in total cost of care savings, right? That is work that the state will have to do, right, over the next 10 years. We've done some of it. To your point, we've done quite a bit of work to pick some of the low-hanging fruit. There are initiatives underway now that should be maintained, EQIP being one of them. You mentioned provider reimbursement. That is, I think, a program that aligns all of the things that you just mentioned, right? It is using value-based payment for providers to align with the incentives of a hospital, right, to lower total cost of care and improve quality through those payment bundles. I think those types of initiatives, EQIP has been successful, and there's a lot of enrollment among our physician community in that program, and a lot of participation by the hospitals to do it. It has generated more savings than it has cost in terms of enhanced reimbursement. Those are the types of things that we still have opportunity to do within the AHEAD model, and we're going to have to work together, I think, as a state to really find those opportunities and bolster them.
All right, thank you.
Just a reminder to everyone that we do have 3 more panels today in this briefing. So we have 3 more questions from our House members. I see there was another from the Senate. And clearly, we are very, very passionate about this topic and want to dig in. And I'll remind everyone that that the executive director, our secretary of health, the assistant to the governor, they're not going anywhere. So you can also continue those conversations offline. And Delegate Shalega, I would also encourage you to make sure you have a conversation so we know exactly what numbers you're looking for. With that, I will go ahead and call on Delegate Martinez.
Thank you, Madam Chair, and thank you, Madam Secretary and fellows, for being here. If you know anything about me, you know I love Prince George's County. And something you said earlier, Madam Secretary, is that healthcare is local. And one of the things I've been doing throughout the interim is serving on our hospital wait time work group at the council level. I know we haven't gotten to that necessarily what is called overview slides just yet, but on the menu of options for the regulatory work group is the elimination of the certificate of need process. That, I really want you to know, is my pick on the menu, and I really want to work with you all on figuring out how do we expand our access to care, because continuously when we've had these meetings, all of them have been public, folks have said the CON process has prohibited them from bringing care to the county. Can you talk a little bit about, I guess, some of the conversations that have happened, if any, around the CON process and how we can just better prepare our communities to provide care at all levels?
I think, Delegate Martinez, I appreciate you raising and giving that, again, that local, what you are seeing on the ground with your constituents. I think this is an area where we will have further conversations, also in partnership with the Maryland Healthcare Commission that does a lot of work in the certificate of need area. So I think there's more to come there for us.
Thank you.
Senator Lamb.
Thank you, Madam Chair, and thank you to all of you for the presentation. I think I want to address Delegate Hutchinson's question there that, there are obviously significant changes that are anticipated as part of AHEAD. And I think given the level of changes, given the removal of Medicare under rate setting, this is effectively the end of our waiver that we've had for the last 50 years since the 1970s. This is going to be a big change for the state of Maryland, with our waiver, going through a massive transformation in a way that is probably not something that we can put the toothpaste back in the tube on. And even though some of these are pegged to the out years, I think it'll be very difficult in this transition. And what we've seen over the last several decades with rate setting and our unique waiver here is now coming to an end. And so with that transition, I am concerned about the level of cost shifting to hospitals when it comes to the $870 million that's being anticipated will need to be picked up. And while, certainly appreciate that we're getting enhanced payments compared to fee-for-service models, and so we're getting enhanced payments in the state, which I think will help. But still mindful of a lot of the cost shifting that's expected to take place here. So, under the new model, I think there are a lot of targets that are still being developed and being considered, which I think we're all going to be obviously keeping a close eye on. But is there any room for more immediate needs to be addressed through inflation adjustments or measurements, labor costs, utilization, anything anticipated from the commission and the like?
Yep. So thank you for the question, Senator. And I would note that the rules of the road will change as you've noted. A lot of the incentives, a lot of the underlying structures are preserved, and so I think we have opportunity to look at what are the needs of the healthcare delivery system, what are the needs of the patients, and doing a lot of the balancing work that we've described here today. I think in terms of the opportunities in front of us now to meet some of the initial needs, well, we just, at the last commission meeting, did touch on one of those immediate needs, right, which is that we have seen over the last couple years higher than anticipated volume, patient volume for respiratory diseases, so flu, RSV, COVID. And so we did approve a policy that's an annual policy. We have assessed this every year, evaluate this every year, and then add to rates the amount of volume over what was anticipated for those conditions, right? That's a really important kind of safety valve, right, for ensuring that there's adequate funding for exactly those things that you're describing: staffing, cost of supplies, et cetera, the variable costs associated with treating those patients. And then we'll have, of course, our annual process right in front of us, starting very shortly of our annual update factor. So happy to come and talk to you about the puts and takes of that as that starts to shape up.
Right, and with the update factors and some of these other factors under consideration, I think, and no surprise to you, I think there have been some anxiety amongst some of the stakeholders on the responsiveness of the HSCRC to be able to account for some of these adjustments that need to be made, whether it's for academic medical centers, whether it's for age adjustments that need to take place, whether it's for accounting for capital costs. Obviously, our baseline is still baselined to 2014 numbers as a starting point. There are a lot of considerations that still need to be kind of accounted for, and that includes some of these population health objectives too. I guess to the committee and also to the stakeholders that are obviously involved in this process, what level of commitment can the agency make to be a little bit more responsive to some of these concerns? Because I think they have pulled forward for quite a while, and so I just want to see what level of kind of responsiveness the agency has to this.
Senator, if I may, I can address that question.
Sure.
What we would say to both committees today, what we would say to stakeholders and what I have said to stakeholders is that as challenges are arising so within the context of hospitals is things like the flu season, things that impact access to care, things that destabilize the hospital. We want to know about them. We have a number of tools. As the executive director said, we'll continue to have a number of tools via the HSC CRC to address some of those. We'll work with this body to address others, but we want to know what those challenges are, and we want to address them in real time. Things like the new agreement, things like HR1, right, which is going to present additional headwinds. We acknowledge that, and we stand ready to work with all stakeholders, including the hospitals in the state of Maryland, which are the key way that so many of your constituents access care in this state. It's essential infrastructure, and we stand ready to listen to those concerns and work collaboratively towards solutions.
Okay, that's helpful. I think some of the stakeholders that have been involved don't feel that has maybe necessarily met the bar of what they would have hoped. And so I think there's probably going to need to be more attention on stepping up to that level, particularly with all the changes and transitions that are coming through right now. Last question then has to do with the uncompensated care rates, where it looks like it could be north of $245 million in uncompensated care expected this year alone, just by some of our estimates. What is the department and the agency looking to do to address the expected kind of tsunami of uncompensated care?
Why don't we do it HSC?
So first, we're working with multiple agencies to get projections on uncompensated care, right? Because it's not a direct pull through from losing coverage to uncompensated care. So that work is underway.
So do you dispute that number?
I don't have a number to provide at this point, so I'll come back to you. But what I would say is twofold, right? One is both the department, the Medicaid program, MHBE, MIA, all the agencies are really focused on mitigating some of the coverage losses, right, that would drive uncompensated care. And then what we're going to be doing is at the HSCRC is going through a policy process to look at our uncompensated care fund and the uncompensated care policy, right, to figure out within the context of the HEAD model and the changes therein, are there changes that are going to be needed at the state level for uncompensated care? And again, what we're talking about here would be the marginal, the marginal increase in uncompensated care for them that is currently borne by Medicare, right? So not the other components of it. So that's why, you know, some of the numbers and projections are complex.
Okay. All right. Thank you, Madam Chair.
Delegate Taveras.
Thank you, Madam Chair. I guess we're all gonna be going to Vapor Rub again, but I have some questions with regards to some of the concerns that were raised by the Maryland Health Association last year. And I know that I remember asking on the increasing and competitive cost of attracting the best residency physicians and such. You know, it's competitive, right? To attract the best and the brightest. It's a competitive process. So when we look at those kinds of issues, when we look at the cost of maintaining equipment and attracting the best in innovation, and as Senator Lamb just highlighted, the increasing cost of these the compensated care, the denials that come through, you know, I mean, you're highlighting about $890 million that may be for 38 hospitals out of 45 that are going to be hit. And there may be more when we look at these other issues. How has the AHEAD model been adjusted to accommodate those issues that were of concern to the Maryland Hospital Association? And what is being considered to close that gap, especially now that access to care may no longer be on the table? And this is all not accounting for labor, union contract negotiations and such.
Yep. So a couple things I would note here. So many of the policies that you're mentioning, the state side of that work, I would flag, and this also goes to Senator Lamb's question as well. We now have published, for the last several months now, have published a policy calendar so that we as an agency are kind of lining up all of these issues that are going to have to be done through the HSCRC policy process over the next 18 months. And several of the things that you mentioned are on that calendar because they are critical. What I would say is two things, right? In a broader sense, you raised attracting clinicians, et cetera, to the state. The multi-agency work group and the administration writ large is focused on workforce issues, which I think when we think about graduate medical education and so forth, a lot of what we're talking about here is putting it in the context of workforce development. So I think that is on that roadmap for sure. The second thing is with respect to the AHEAD model specifically, right? Some of the costs that you're mentioning, the HSCRC in our rate setting has always incorporated a high degree, for example, of GME reimbursement, right? What the work that was done over the last few months of the negotiation was really try to establish, and we got the commitment from the federal government, right, that a lot of those costs that are currently in rates will pull through to the baseline rates that they will establish in the Medicare portion of the global budgets in 2028. Why is that important? That's really critical because it means that those costs are baked into the global budgets, right? That revenue is baked into the global budgets going forward. That's an important starting point, right, for us as we think about as we think about how the global budgets will evolve over time. That was in direct response, right, to some of those concerns around, hey, are these costs going to be considered within the AHEAD model?
Thank you, and just for the record, I do have paperwork, just in case. I'm ethnic like that.
Thank you, Delegate Johnson.
Thank you, Madam Chair, and thank you for coming to give us this information today. We've made a lot of efforts in Maryland to stabilize the market with the reinsurance program. So with the cost shifting and the higher premiums, do you feel that that will erode that program in any way, and are you planning to monitor that?
I can speak to that. So absolutely planning to monitor it. I mean, and one of the real considerations as we went through that process was really thinking through what could potentially be destabilizing for those markets. That was a huge consideration there. So, I think where we landed was a place of, stability, right, as best as we can have. But then again, we'll do the continued monitoring to ensure that we're not having unintended consequences, right, for those really important markets that we've kind of really fought so hard to stabilize over the years, particularly the individual market.
Thank you. Thank you, Madam Chair.
Thank you very much. Thank you for your presentations. And I just wanted to say, to the points that have been made, the nation is actually watching. We are the first, and so they're watching what we're doing. So I appreciate that this is a very deliberative process. I was glad to hear you and so many of our members talking about, affordability and quality, not just of insurance policies, but of health care service. We are going to have to balance the requirements of the affordability and efficiency with maintaining quality, patient-centered, outcomes-driven healthcare delivery. And I was going to ask how, but instead I'm simply going to ask, isn't that so?
Well done, Madam Chair. So thank you all very much. I'm really sorry we've had you on the hot seat for 1 hour and 45 minutes. And I hope the next 3 panels don't go quite as long, but thank you very much for all your work. And again, to the Secretary and Dr. Crom, you've really been great to work with through all this, and I really appreciate all your help. Thank you. So our next panel is the Maryland Hospital Association, and our prior chair, the Senate Finance prior chair, Melanie Griffith, is here as president and CEO. Tequila Terry, Senior Vice President, Care Transformation and Finance, and Dr. Mohan Santha, President and CEO of University of Maryland Medical System. So welcome, and who would like to start?
Good afternoon. Thank you, Chair Beidel, Vice Chair Hayes, Chair Bagnell in her absence, and Vice Chair Cullison, and to the members of the joint hearing room that are representing Senate Finance and the new Health Committee. For the record, I'm Melanie Griffith, President and CEO of the Maryland Hospital Association, and it is our pleasure to present to you this afternoon and just share some insights on the topic that you've asked us to address, which is ahead. As you all likely know, the Maryland Hospital Association has an amazing team that you all hopefully have been interacting with for some time. And we also have some incredible members, many of whom are represented in this room, and wanted to acknowledge their presence and support of the work that we all do together. Also wanted to acknowledge the previous panel and the work that we have done together over the past 2 years, negotiating the AHEAD Model 1 and AHEAD Model 2 with the new administration, and the work that's gone on for the past year. As you all also likely know, Maryland's Hospital Association represents the hospitals and health systems across the state of Maryland, from Crisfield to Cumberland, from the northernmost parts to the southern tip of the state. And the logos of the hospitals that we represent are on the screen, so hopefully you all will recognize those hospitals. Want to thank each of you. Many of you have been visiting with and working with the hospitals in your districts and in the communities that you represent, and your partnership has been invaluable to the work that happens as Maryland's hospitals take care of our communities. The 50 hospitals and 9 health systems in this state operate 24 hours a day, 7 days a week, 365 days of the year, caring for over 4.9 million people annually. So basically, to put it in summary, Maryland's hospitals drive health and economic vitality of our state. You can go to the next slide. Collectively, our hospitals power Maryland's economy with an economic impact of $35 billion. Hospitals support over 168,000 jobs. They generate $9 billion in wages and benefits, and purchase over $4.6 billion in goods and services, all while providing $2.3 billion annually in community benefits. These are initiatives, activities, and investments to improve the health of the communities they serve. Add to that $878 million in uncompensated charity care hospitals provide to their communities each year, and I heard that raised through a number of your questions. This ensures that patients who cannot pay for care still have access to necessary services. You can go to the next slide. Wanted to make sure, just to level set, I know everybody is very familiar with the healthcare continuum, the healthcare ecosystem, however you reference it in this state, the very complex system of care delivery, and doesn't look exactly like it looks in other states, as you all know. Well, in Maryland, our acute care system is at the very center of the healthcare delivery system, providing life-saving care for all of our citizens when they show up and need to be responded to by those committed workers that have been working throughout the years, days and nights, to make sure that their needs are met. They deliver high-quality care for acute illnesses and injuries, again through our emergency services, manage complex care, and ensure smooth transition when available to post-acute rehabilitative care for recovery. You can go to the next slide. Basically, for my opening remarks, Madam's Chair, I wanted to make sure that you all understood that we understand as the hospital industry in the state of Maryland, that we can't do it alone. Care takes all of us, and that is the message that we hope, if you hear nothing else from us today, you understand that. We understand that in order to be successful delivering the care that Marylanders depend on, we've got to be a part of a system that doesn't hold us singularly responsible for the well-being of our communities. We are partnering with those in behavioral health. We're partnering with providers, post-acute care, home health, hospice care. Hospitals are working with all of these entities in order to make sure the needs of our communities are met. And we are doing that and doing our work together as we prepare for the AHEAD model, which presents a tremendous change across our healthcare system. The AHEAD model will maintain some of the investment that Medicare provides to the state so that we can focus on building primary care and launch population health initiatives while focusing on transformative care in our hospitals. But that being said, there are also headwinds that hospitals will face. To address the anticipated headwinds facing us and ensure that Marylanders have the acute care services that they need, it will take all of us working together, and that means we're looking for your partnership too. We understand, and as you heard from the last panel, we talked a little bit about the respiratory surge issue. We're working with patients to make sure that they know the right place to receive care for the issue that they're dealing with. It's going to take all of us working together, and it's going to be critical that we work together to ensure that Maryland is successful as we move into this AHEAD model. And so with that, Madam Chairs, I'll pause and turn it over to my phenomenal colleague, the Senior Vice President for Care Transformation and Finance, and Tequila Terry.
Thank you, Madam President. I'm delighted to be with you all. Before discussing the AHEAD model, what it means for hospitals, we thought it was important to note that the AHEAD model is replacing what we have had for the last 5 years, which is called the total cost of care model. And that ended on December 31st. And under that model, hospitals and Maryland as a whole has had some great successes. Under the total cost of care model, hospitals participated in global budgets set by the Health Services Cost Review Commission. They took on responsibility for the cost of care, not just for people who visited hospitals, but for people out in the community that were assigned to them, and they were responsible for managing cost of care and quality. They initiated and led a number of care quality improvement strategies. And they led population health and access to care initiatives. So throughout the model, the hospitals were very committed to really working on key areas of opportunity for Marylanders. And one of the places where arguably there has been the greatest success from the work and efforts of hospitals is that they have worked really hard to lower avoidable hospitalizations. And what I mean by that is that across the state, hospitals have really focused on getting patients care in the most appropriate community setting so that hospital care is available for those who truly need it most. And so throughout the last several years, they have focused on lowering potentially preventable admissions. So making sure they are working with patients who come into hospitals to triage the issues that they have and ultimately help them so that they don't necessarily need to stay in the hospital for an extended period of time. They have worked to make sure that when people come into the hospitals, they also are doing a really thorough analysis of what their needs are so that they don't get readmitted. And finally, for people who come in because they have chronic conditions that they are struggling with, they work with them and follow up after they are discharged. And so together, these strategies have really been a monumental effort that the hospitals have taken to ensure people get the care that they need in the right place and the right time. And that has actually resulted in some tremendous successes across the state. Maryland has experienced a number of great benefits from the total cost of care model. Through those efforts of reducing avoidable hospitalizations, making sure that they are efficient and effective in the way that they are delivering care, hospitals have been able to generate $4.8 billion in Medicare savings. They've also been able to slower and really bend the cost curve. So when we compare ourselves to other states and to the nation, we see 34% slower Medicare hospital spending growth than the nation. Additionally, those savings and that efficiency actually translates to lower costs, lower expenses for commercial insurers. So the model actually resulted in $1.28 billion in lower costs for payers in Maryland compared to their peers in other states. So they are actually getting paying less for hospital care in the state of Maryland. So we have really been successful from a financial standpoint of bending that cost curve. In addition to that, we've been really successful in improving quality. There are places where we're still got work to do. We still have work to do, but we have been tremendous in reducing the amount of preventable complications in hospitals, and we have a better than national Medicare readmission rate in hospitals. And so the model has had tangible results for Marylanders statewide. And that's important context for us to think about the future, because we're really building on the experience in the total cost of care model as we move into the AHEAD model. As President Griffith noted, AHEAD really brings some key opportunities to the state of Maryland. It gives us the opportunity to build out primary care infrastructure across the state so people have access to prevention-based services. And there's a tremendous amount of focus on population health priorities, like focusing on colorectal cancer screening, measuring diabetes control, following up with people who have mental illness after a hospital visit, focusing on food insecurity, and measuring the number of healthy days people have. And so there are some really good elements to the AHEAD model that the state will be implementing. And these actually represent opportunities to achieve the vision of health that the Secretary described. Hospitals are looking forward to being part of that work. And while they're looking forward to partnering with state officials on those elements of the model, it is important to underscore that this is a new version of the AHEAD model that is different from the prior total cost of care model, and even different from the AHEAD model that we started negotiating in 2024. This new AHEAD model represents a fundamental shift in the way that we have thought about the Maryland model. It's not the all-payer design that we have historically had for decades in the state. It is different. And so that's an important framework for us to sort of think about when we think about what does the AHEAD implementation mean for hospitals. This model, this new version of the AHEAD model, actually really is going to require hospitals to do much more than they've ever done. So as the Secretary and John Crum Executive Director Crum just mentioned, there are some significant changes in the way that the model is designed. So hospitals will be asked to generate more savings with less funding. And that's because of two things that I want to highlight. First, the new AHEAD agreement increases savings requirements from $230 million, which was what we were negotiating in 2024, to now $460 million. So that's doubling the savings amount. So you have more savings to achieve. In parallel with that, hospitals are going to have $870 million less in payments from Medicare and Medicaid. So these two things are happening together because of the AHEAD model and the HR1 legislation that passed at the federal level. So those two things are the first thing that we would highlight. Additionally, hospitals are going to be navigating complex federal and state structures. So as I mentioned, this is a very different approach than what we have had historically in the state. Under AHEAD, hospital global budgets and quality policies for Medicare will be set by the federal government, the CMS Innovation Center, or CMMI. So they run that part of the hospital operations, the Medicare portion. The state, through HSCRC, will set the hospital global budgets and quality policies for Medicaid and commercial payers. So if you can envision a hospital navigating now not just a state-controlled structure, but these structures that the federal government and the state will be working on in tandem. And then the last thing I'll highlight is that the model will expand investment and really set an expectation that hospitals should be doing more in care transformation and population health. And under this, hospitals will be required to lead population health initiatives and submit plans of their work to CMS. So this is a very different dynamic than what we have seen historically. And so hospitals are certainly working to understand how they can be supportive of state efforts and how they can manage to this new normal. I do want to just underscore, one thing that is really going to be significant. And again, it's that hospitals are confronting a total reduction in payments from public payers, that's Medicaid and Medicare, of $870 million. And what you just heard from the prior panel is that only about half of that reduction would be addressed by the cost-shifting policies that are under consideration. Hospitals that are serving in largely Medicaid populations will be particularly disadvantaged because they don't have the ability to make up those losses through the commercial cost shifting. So this is an issue that we have to look at much more closely and understand how do we come together and find a solution for what, again, will be the new normal as we move forward. And so as we think about this future under the new design of AHEAD, it's important to note that hospitals are absolutely working to prepare for the AHEAD model. And in parallel with that, they are thinking about how do they serve their communities? How do they make sure that they can meet the needs of communities? So they are really looking at these three things that you see on the slide. Number one, they're looking at how do we really provide those critical healthcare services that communities need and rely upon us for. So really assessing what communities need in order to move forward. They're thinking about clinical care and how to ensure patients are receiving safe, high quality, and effective care so that we get the best outcomes. And they're looking at their operational design. So they're looking at what I would call people, process, and technology. They're looking at how to serve patients to achieve the best patient experiences. And that means looking at people, understanding how they can engage the best physicians, the best nurses, They're looking at process, making sure that they have a way to manage capacity, the right technology in place to manage this ahead transition. And of course, looking at their processes, because there will be a number of operational processes that have to change when you're now navigating this bifurcated system where the federal government sets certain policies and the state sets other policies. So it's really important that everyone understand that hospitals are really working hard to, again, prepare for the AHEAD model. In parallel with that work to prepare for AHEAD, there are some everyday things that we work with hospitals on and that they are going to be facing, and these are headwinds. So we have the AHEAD implementation happening, and then we have these on-the-ground headwinds that are happening that hospitals have to prepare for. And these are the things that you see on the slide. So there are demographic changes. So we've talked about this, and I think we mentioned this last year when we addressed the committees. Maryland's patient population, or population in general, is changing in real time. It's aging, it's becoming more complex, with nearly 20% of Maryland's population expected to be 65 or older by 2030, and many averaging 3 or more chronic conditions. So this will certainly have an effect on how hospitals prepare for the future. Additionally, hospitals are preparing for, again, the people part of the planning that I talked about. So the workforce, and in particular, physician workforce right now that is underfunded. So I'll talk a little bit more about that. They're also preparing or really dealing with the effects of a growing number of denials, a situation where they have delivered the service for a patient, they have issued a bill to the insurance company, and the insurance company rejects the bill and will not pay. And so that denial those types of situations with denials are increasing, and so I'll share more on that. Post-acute resource gaps. So it is important that, again, we think about the importance of the other parts of the healthcare system. And so post-acute is an important part that hospitals rely upon. And when we say post-acute, that refers to the care that patients need after they're ready to leave the hospital, but they're not quite ready to go home. They're not fully recovered enough to go home. So that means things like skilled nursing facilities or rehabilitation centers, long-term care facilities. So those resources that are in between. And when those resources aren't available, then that creates a challenge for the capacity and the throughput that hospitals plan for with patients. And so that is certainly a headwind that will be, hospitals will be grappling with. And then layer on top of that all of the federal policy changes that we have been alluding to throughout today's meeting and the implications that that will have on uncompensated care and the number of people in our state who don't have insurance. And so these headwinds are coming at a time when we are also preparing for the AHEAD model. So that is really important. So I want to dig into a couple of these just a little bit more, just to give you a bit more context. So physician costs. You'll remember last year when we addressed the committees, we talked about this issue, and it still persists. Hospitals continue to struggle with the rising cost of essential physician coverage. The current HSCRC global budgets and rate structure does not include a funding mechanism to cover the costs of hospital-based or contracted physician services. I want to say that again because I think it's really important. The global budgets that we have for hospitals today do not have a funding mechanism for physician resources that are just critical to hospitals. Can you imagine a scenario where a hospital doesn't have emergency department physicians, obstetricians, anesthesiologists, behavioral health specialists, radiologists, internal medicine resources? This is what we're talking about. we're not talking about, those things that are optional or cosmetic. We're talking about the very foundation of hospital care that is not today built into the way hospitals are paid through global budgets. And that amount results in, or that lack of a reimbursement structure results in an $890 million gap that hospitals are currently absorbing. Because they need these resources, they just dig into the available funding that they have to subsidize this. And so it's an important piece to underscore. And so as we think about the rest of the legislative session, this will be a place where we will be asking for your help to get a solution to this issue in particular, because the losses are unavoidable in this space. These resources are critical to hospitals. The other point that I want to just underscore is around denials. And again, this is a situation where the care has been rendered, a bill has been submitted to an insurance company, and the decision is made not to pay. And so denials are really, rising, and we're seeing now an alarming increase that exacerbate really the financial strain of hospitals. For example, as you see in the chart here, the rise has continued since fiscal year 21. And imagine if you were a patient and you have one bill, let's just say for example, and you're at the ED, 1 in 7 patients is going to get a rejection on the bill that they receive from their insurance company. And so it happens in the ED, it happens in inpatient settings, and it happens in outpatient settings. And the concern that we have is obviously that patients are ultimately affected in a couple of different ways when there is a denial. Number one, it makes them more hesitant to get care in the future. So patients then start to delay or forego care because they don't want to get left with a big bill. It also creates a situation where, as we think about when they do come in, they're probably going to be sicker. And so that means the cost of their care is going to go up. And so we're creating a situation where the denials are now creating a long-term issue both for outcomes as well as cost. And certainly from a hospital vantage point, this adds to the financial pressure that hospitals face when it comes to managing their budget. When they have delivered these services in good faith, or even attempt to come up with a care plan and they get a denial from an insurance company, it creates a financial burden for them, particularly when it's a service they've already rendered. So it's important just to underscore the impact that denials are having both on costs and the care of people around the state. So in addition to those things that are happening, we know that there's a lot spinning in the federal space, and there are a number of federal policies that are expected to result in significant coverage losses for people across Maryland. So the HR 1 law that passed earlier, actually in last year, really creates new requirements for Medicaid that results in what the Maryland Department of Health estimates will be somewhere between a 12 to 15% decline in Medicaid enrollment. Additionally, the Maryland Health Connection, or the Maryland Health Benefit Exchange, is expected to see an additional decline in people who are enrolling in those plans of up to 15% because the federal government hasn't extended the tax credits or the subsidies that they are offering for people who get their coverage on the health benefit exchange. And so these two factors, these two federal changes, are going to have a significant impact on people across the state. And what that means for hospitals is that they have to prepare for what will likely be a tremendous increase in the number of people coming to hospitals who are uninsured. I think you heard on the prior panel that there are estimates that uncompensated care could increase as much as $245 million in the 2026 alone. And again, without coverage, Marylanders may not get the care that they need. They are fearful of a big bill that they cannot afford. And again, that is ultimately going to lead to worse outcomes across the state and higher long-term costs. And, it is important to note that this will likely disproportionately impact people of lower income and immigrants. And so, again, this is something that's really important for us to understand what the downstream impacts will be of some of these federal changes. And so with that said, again, I will just emphasize that the AHEAD model implementation is moving forward. There are some challenges hospitals are working to address, but they have to do that in parallel with also addressing these headwinds. So the strategies that they will be employing is really to make sure that ultimately the people across the state get the health care access that they need, get the acute care services that President Griffith described earlier in the presentation, so that ultimately we have healthier Marylanders. And so with that, I want to turn it to my colleague, Dr. Mohan Santha, President and CEO of the University of Maryland Medical System, and also the MHA Chair of our Council on Financial Policy, to talk about some of the frontline experience that he has as we are thinking about what AHEAD will mean for hospital care. So Dr. Santha, I'll turn it to you.
Thank you and good afternoon. Chair Beidel, Chair Bagnall, Vice Chair Collison, Vice Chair Hayes, thank you very much for the opportunity to speak before this joint committee. My name is Mohan Santha. I am privileged to serve as the President and CEO of the University of Maryland Medical System. We at the University of Maryland Medical System are the state's largest healthcare delivery, hospital delivery system. Again, blessed to serve counties across the state of Maryland, communities across the state of Maryland. In total, we are responsible for delivering over 25% of hospital-based health care in incredibly diverse geographies across the state. We are blessed to have 30,000 team members who are incredibly committed to the mission of the University of Maryland Medical System. We are, at our core, an academic health system with a mission that is rooted in delivering high-quality, leading-edge clinical care, educating the future healthcare workforce of our communities, and driving clinical innovation. When you think about our size, our scale, our scope, my hope is to give you some perspective from our lens about what the evolution of the unique reimbursement model, the payment model, is in the state of Maryland. And I want to start because I think it was Delegate Hutchinson and Senator Lamb who addressed the question of, so are we unique? What has changed? And I would, from my position, I would say that the state of Maryland, again, regardless of anybody's politics, has moved further and faster than the rest of the nation in evolving to a value-based healthcare delivery system. That has not come without challenge, but a unique asset that we have had, a tool in the toolbox that we have had along that journey, has been the unique reimbursement model that hospitals have lived under within the state. And I agree, Senator Lamb, there has been a sea change in that model that we must all recognize. I still believe that the model is a unique asset to the state of Maryland. I still believe that there is value to be created. And I do say that the vision that the state has had for a more equitable health system is driving the state of Maryland in the right direction. But I also want to be transparent and tell you that from the lens of the hospital, the delivery system, that is the regulated entity that we are talking about today, there is a fragility to our reality that has to be balanced with the optimism that we hear as we talk about the evolution of the plan and the model that you've heard discussed. There is no question that the AHEAD model, the uniqueness of the Maryland model, has to be able to address existing realities in terms of financial stresses, workforce realities, access gaps, as we go forward into the new world that we are going to all be living in. I believe that the governor and Secretary of Health have had the right vision and the right goals as they've laid out for policymakers and regulators a strong framework upon which this model can be built to go forward. And I want to recognize all of the efforts that they've put forward on the behalf of the citizens of the state of Maryland as they've negotiated now with the new administration, having just completed that negotiation not more than 18 months ago with the previous administration. I also want to recognize my colleagues within the hospital industry because we also have engaged with the federal administration directly to ensure that the federal administration understands the realities that the delivery system in the state of Maryland is facing as they've thought about the evolution of the model. And I believe, from my seat, that it is that direct engagement that has also provided value in how this model has been constructed. But again, as the University of Maryland Medical System, I say again, when I talk about our size, our scale, our geographic scope, we are at our foundations an academic health system rooted at an academic medical center. But we are also the health system that is transforming rural health care on the Eastern Shore of Maryland. We're also the health system that has taken on the responsibility of transforming healthcare delivery in Prince George's County, a county of 1 million people, whose historic healthcare access within the county was really limited to trauma and safety net healthcare within the county. And we have taken that challenge on. We are traditional suburban healthcare access points. We are also a health system where we are the only acute care healthcare access points within entire counties. For example, in Hartford County, in Charles County, as examples. So we have, I would say, incredibly diverse experience, and it's that experience that I'm hoping I'm able to articulate to you, both where I see the opportunity and where I see some of the challenges as we go forward. My entire healthcare career has been at the University of Maryland, both within the School of Medicine and within the medical system. And I consider it a great privilege to be a physician within the state of Maryland, a state that has very purposefully taken on the challenge of driving equitable access, equitable healthcare outcomes for decades. And this model has been a cornerstone to that. But this model is absolutely undergoing an evolution that requires our collective attention. So when I think about those changes, I think about one point that I think is critical, and it's been discussed on both panels that you've heard, and I think my colleague Tequila just mentioned something that is critically important. That as the hospital industry, we are now facing a reality where we will have to be accountable, not just to the state's regulatory oversight, which is an accountability that we've understood for decades. But now, in addition to that oversight, we will have to, as an industry, be accountable to the federal oversight that comes when the federal government takes Medicare oversight and determinations of global budgets to the federal level. To Senator Lamb's point, that is the sea change. The notion that we have moved away from an all-payer model that has been the regulatory cornerstone of the state of Maryland, that is a sea change that the hospital industry sits in the middle of, and that is a critically important factor when you think about some of the challenges that we are talking about. Another objective reality that you all should, I'm sure you're aware of, but it is important to recognize, is what is the current financial condition of Maryland hospitals as we go into this model change. And that is not subjective. You don't have to just ask me how the medical system is doing. That is objective data that needs to be looked at to say, how is the state hospital industry financially performing as we go into these changes? And what I would tell you, again, as objective as I can be, is Maryland hospitals have lagged behind national benchmarks for hospital performance for a number of years. And now we're going into an evolution in the model. And I don't say that to disparage the model. I say that so that we are all realistic about the challenges that we are facing as this model evolves. I look at this and I say, when we think about what does it mean for hospitals to be lagging behind national performance metrics, when you think about what the healthcare industry, the hospital industry does within the state of Maryland, I want you to think about the economic engines that we are within our communities. I have been fortunate to serve in a role as the chair of the Greater Baltimore Committee, the economic organization that thinks about economic development across the Baltimore region, 5 counties across the region. And there is no question that one of the state's differential assets for decades has been the healthcare ecosystem in the state of Maryland. There is no question that we are economic drivers, that when you think about life sciences, healthcare delivery, higher ed, healthcare is at the cornerstone of the economy of this state, and it has been a differential asset. And it is critical that we preserve that asset as you think about this model, and it is work that we, as the healthcare industry, the hospital industry, look forward to continued partnership with the state as we go forward and take on some of the challenges associated with the evolution of this model. When you think about hospitals performing behind their national peers, I think about it through the lens of, well, what are the investments and the bets that we are able to make in that evolution of healthcare? So when you think about rural healthcare, how is it that we can invest in a healthcare delivery system in rural healthcare when the rest of the nation hasn't figured rural healthcare out? How is it that we're able to do that? In part, we're able to do that in partnership with the state with this model. And now we're going to have to make sure that the federal government understands that as well. Same is true for safety net healthcare. When you think about safety net healthcare, and when you think about portions of our community that have been historically challenged for healthcare access, what will it mean for us as a delivery system to be able to meet those unmet needs when the stresses and the strains and the realities that you've just seen presented to you with numbers means less resources as we try to solve these challenging problems. But I will stop by saying I am a glasses half full human being. I believe in this model. I believe that there is opportunity for us to come together. You've heard the previous panel, you've heard from my colleagues at the MHA say with clarity that the hospital industry stands ready to lean into these challenges. But we need to ensure that our voices are heard. And I'm going to say it as clearly as this, not simply as a stakeholder in this process, because at the end of the day, we are the regulated entity. It is the resources that come to hospitals that all this conversation is about. And so because of that, we deserve to ensure that our voices are clearly heard. And I know from my lens, for as long as I'm sitting in this seat, I'm going to make sure that it's done that way. Thanks so much for your time, and happy to take questions.
Much for giving us this opportunity. We're available for questions, but just wanted to make sure that in all that has been shared by my colleagues so eloquently, that you just keep in mind this is a change. This is a new dynamic. There are new alignments required, all at a time when hospitals are still financial stability continues to be an issue for many of our hospitals, while we're still dealing with issues like AI. Some hospitals are still dealing with the impacts of the COVID pandemic from a few years back. They're dealing with capital and growing infrastructure issues, growing threats in cyber. So we have all of these issues facing us as we work on transitioning to this new model. And please know that the hospitals in Maryland remain committed to providing safe access to health care for all Marylanders who require it. Thank you.
Well, thank you to this panel. You've done a great job presenting the issues and the opportunities, and I really appreciate it. President Griffin, it's been wonderful working with you the last year through all of this. And of course, Dr. Suntha, you know, I have so much respect for you and the work that you've done. So thank you all. I'm going to call one of my senators, and then unfortunately I have to leave. I have an annual board meeting to attend that I'm very late for. But please don't take that as a slight. It's just something that I'm required to do. But Senator Washington, the floor is yours. Thank you very much.
Thank you, Madam Chair, and great to be here with all of you. Thank you for the great presentation. I have a question. I went to the MHA event earlier today, and I was intrigued by the presentations and just everything that was happening there. And also we're talking about the HEAD model today, and I wondered if you can just answer this quick question. Thinking about the HEAD model and the hospitals working with the primary care, behavioral health providers, social service agencies, and any other local governments to implement this model, what are you doing to partner with those external agencies or groups to on the ground? And how does it look like formally?
Thank you, Senator Washington. Great question. We have been from day one working with other committed stakeholders who are working to address the healthcare needs of Marylanders. From behavioral health, we work with MedChi, our physicians group. We work with other stakeholders. And I will tell you that one of the points that Dr. Suntha made that is really, I hope you all take this point, is we are the regulated industry in the state through the HSCRC, but we cannot do it by ourselves, right? We have to have partners from other stakeholder groups talking about home health, and we've met with long-term care providers, the rehab facility providers, and what we've been trying to work on is making sure that everyone is committed to the success of this model and to working with our hospitals to ensure seamless healthcare delivery. We know that that's not happening in many jurisdictions in the state and that we have a lot of work to do together. We've been meeting with the governor's office, the administration. We've met with the HSCRC, the Department of Health, and we have all partnered in our commitment to advance the work to make sure that the care gets delivered to those who need it. But we have a lot of work to do, and we can use your help too, Senator.
Okay, put me in.
Thank you.
Thank you very much. Thank you for your presentation and for articulating this really complex journey in a way that we could understand. Delegate Hutchinson.
Madam Chair. So it must be an Eastern Shore thing because I like numbers as well. I'll ask the question to Ms. Terry. I'll let the CEO is off the hook here. So in your presentation, I think you said about $1.3 billion of savings to the commercial payers over a 5-year period. And I'm just trying to follow this money. And we're starting now to talk about cost shifting to the commercial payers. But doesn't that in turn just mean the commercial payers are now going to be raising their premiums, which then affects and comes back to the constituents that we're affecting the affordability of healthcare? We're already talking about a 13% rise in premiums, and we're lucky that it's only 13%. Yeah. So I just can't keep following this money around and saying, isn't this then going to come back to uncompensated care, people not getting insurance as a result of this? What's your reaction to all that?
Yeah, I think you've hit on some really important points, and a word that we often use when we think about all of these different policy issues is the need to balance, because all of these, there are a finite amount of resources. We understand that. And the new model is testing our ability to balance. So to your the first part of your question, the 1.28 billion, what that it represents is, as compared to commercial payers outside of Maryland, the ones in Maryland, commercial payers in Maryland, actually pay 20% less on average for hospital services. And so they get a discount. They're getting a better deal in the state of Maryland for hospital services. And over time, that adds up. And so that is how we've accumulated so much savings generated to commercial payers, is because of the lower hospital reimbursement for commercial services, commercial payers. But to your point, as we think about, what the regulatory working group is going to be putting together, is really how to balance all of these aims. And so in our historic model, if you can sort of envision like a bar chart, where you have Medicare, Medicaid, and commercial payers, and they're all paying the same amount. What's happening going forward is Medicare and Medicaid are coming down, and so the idea is to raise the commercial payments to offset that reduction. And so to your point, it does mean that we have to think about affordability, and that's a really important issue for all of us to be considering. Affordability is really important to us. Every person in this room is a consumer of healthcare services at some point, right? And so affordability matters to everyone. Everyone, or many of us in this room, may also need hospital services at some point. And so, the policy objectives have to balance both of those aims, affordability and access to hospital care. And so I think that is what, our message has been to policymakers and regulators across the state, is that we have to look for ways to balance those objectives. And the proposal that they've come up with really is aimed to minimize impact to, sort of ratepayers, consumers at the end who are buying premiums. But we have to balance that again with, at some point, everyone is going to need hospital care, whether it's for those acute care services that were described, accidents, strokes, car crashes, those sorts of things that happen on an everyday basis across the state, that we need that too. So I think, our model is intended to focus on managing that dynamic. And so that is what we would really encourage policymakers to think about, is how we achieve that balance. Hospitals have done a really good job of, managing the avoidable use of hospitals, right? Getting people to lower cost settings. And that's really important. But there's probably a limit to how much more we can do in terms of getting people out of hospitals if they truly need hospital care. And so that cost has to be managed throughout our system. And so that is what we continue to emphasize, is that, the commercial payers have had, these lower rates historically under the model. Going forward, providing, their fair share of resources to help us navigate the future, where things are going to be very different. And again, in that bar chart depiction, where Medicaid and Medicare are contributing less in the state, so those costs get shifted over. So,
just to follow up to that, though, so those negotiated rates that you're talking about, are those locked in? Are we guarantee that they'll remain, or are they just going to come back and try to put more squeeze on you for lower reimbursement?
So I think that is one of the things that is really uncertain. I think it was very late in the negotiations where CMS introduced the idea of making significant modifications to the Medicare investment in the state of Maryland. And so we do have, an agreement now, a written agreement that sort of locks in the terms of the new AHEAD model. But, this is a time of a lot of change in the federal government. And so it is one of the places where we will continue to watch and see if over time circumstances or terms change from the federal government. And I think that's going to be an important element for all of us to watch in this new AHEAD model.
Great. Thank you very much. Thank you, Madam Chair.
Senator Ellis.
Thank you, Mr. Chair, and thank you for panelists for your very informative briefing. And my question is directed to Dr. Sunta. So one of hospitals in the system is in La Plata in Charles County, and my job to all my constituents when I roam around Charles County, whether it's Walmart or Lowe's or Home Depot, is to translate Annapolis speak to my constituents. I know we're talking about different models. There's the total cost of care, there's a HEAD model, and all that means nothing to my constituents. They want to know why they were in a car accident and there was a diversion away from the hospital and the ambulance diversion to go far away, what seemed like a regular day. They want to know why, after many hours of waiting for ER, they just had to walk out because no one came and even triaged them. They want to know why, they're in the hospital and they hardly get to see a nurse because Southern Maryland, Charles County have the worst nursing shortage in the state of Maryland. Those are the questions they want to know. I'll just stop at those. I know it's a big system, but I also know that Charles County has grown in Southern Maryland region. I mean, we draw on more than Charles County, from Southern Prince George's County, St. Mary's County, and of course Charles County need services. Why? The hospital is basically the same as when my son was born there 30 years ago. Got great care, but it's basically the same. I want to know why there has been plans for many years to build a new hospital, especially in the Waldorf area, which is in the top 5 largest cities, you can say. It's unincorporated, but it's large, over 80,000 people, grown tremendously. Charles County's population doubled in the past 30 years, and still in the top 2 fastest growing counties in the state of Maryland. We go back and forth between another county in the northwest. So what kind of analysis, decision-making going into the growth in the area, the need for services in the area, why my constituents have to wait 7 to 11 months for appointments with healthcare providers, why we basically have to go out of the county to have our babies delivered because we can't really take care of the needs there. What goes into the planning phase of saying this area has grown so much, but I hear absolutely no movement on even the land that's purchased in Waldorf by the La Plata Hospital, just sitting there, and there's no movement on that. Can you enlighten me with the decision-making so I can have some answers for my constituents?
Sure, Senator. So first, thank you for your question, and thanks for your commitment to the citizens of Charles County. I think I'd be happy to take this offline and give you a greater perspective of how we've thought about the growth that we absolutely agree with you. When we look at Charles County and we see the population growth, the need for healthcare services continues to grow. We do believe we have made some significant investments in the county, most notably just recently in this year, opening up the brand new emergency room that was tens of millions of dollars of investment because of that access point issue. We also agree with you. We have work to do, not just within the medical system, but I would argue within the state of Maryland, to think about how do we increase provider access, especially to primary care, in communities such as Charles County, where there has been like many places across the state, under-resourcing of primary care. Our vision as the medical system is to partner with our public school of medicine to increase the training opportunities for students, for trainees in outlying areas, not just in Baltimore, so that they can experience life in your example, Charles County, and be attracted to the communities where they could then be employed by our health system, or MedStar, or Kaiser, or the other healthcare delivery systems that are also in the county. In our view, and the approach that we've tried to take in the county, is no pride of ownership. We believe that our health system has to partner with other health systems to deliver on the access issue outside the walls of the hospital. At the same time, doing the work of imagining what is the capital needs to invest in modernizing the facilities in Charles. That goes back to this fundamental question of what is the financial performance, not just of Charles Regional Medical Center, but of our health system overall, to be able to afford the types of capital that you're talking about. And that's where I would hope that we could lean in together and partner to understand, well, what has to be true in financial performance of organizations to take on the incredible capital appetite of healthcare delivery. One reality, objectively measured, that we should all be able to talk about is, what is the age of the facilities of hospitals in the state of Maryland? You just described Charles County. I promise you, across the state of Maryland, we see how we are compared to the nation. Well, and that is a consequence of needing resources to invest in those capital investments. And so I will take it offline with you, sir. Me and my team would love to have you to spend some time, talk specifically more about what capital investments we're making in Charles County as well.
Yeah, thank you. And because, I've one follow-up, Mr. Chair, okay? And so I've spent a lot of time during previous interim visiting the hospital in Charles, the Capital Region Hospital, and basically when that hospital in Prince George opened, it was already over capacity. And so in the entire region, the state has done a terrible, terrible job. And the need is there. And I'm just really want to do a lot of focus in this area and help be part of the solution and not part of the problem. And I hope you feel the same. Thank you.
Absolutely, sir. Thank you.
Thank you very much. I am going to need to step away for in a moment for another meeting, but my amazing Vice Chair Cullison is going to take over. With that, I'm going to go ahead and call on Delegate Alston.
Thank you, Madam Chair, and I would like to thank the Hospital Association and all of your members for the hard work you all do. As we all know, in our state, many of our residents turn to hospitals for their primary care because of some of the lapses in our system. So I'm hopeful that this new model will help to alleviate some of that stress and burden on your systems. My question is twofold. One, you all mentioned almost an $890 million gap in addition to the fees that were mentioned in the prior panel. It's almost $1 billion worth of a deficit that it looks like you all may be facing on an annual basis and growing as large as 1.2, if my math is correct. And it also appears that the state has to make some choices to CMS by January 1st of 2027, but the report is not due to the governor until June of 2026, which is after we will be out of session. Do you believe your interests are going to be adequately represented since you're not a part of the multi-agency regulatory work group? And Dr. Gunther, I'm grateful that you highlighted your concerns about being regulated but not being at the table. While we're here for this 90 days, do you all believe there's any legislation that we need to introduce now in order to address this? Because my concern is that by the time the work group makes its decision in June, we'll be out of session. This stuff will go into effect once we get back in session, and there won't be time to address these gaps. And Madam Secretary, I saved the question for this panel, but I do hope that they will be more than just a stakeholder in this process, because so many residents depend on the care that they receive from the hospitals as life-saving as well as preventative. And at this juncture, our state is just not prepared to take that on, and we can't saddle them with $1 billion worth of deficit and expect to still receive the care that our residents need.
So, yeah, thank you for the question, Delegate. And again, with the lens of glasses half full, I will say I do believe that the administration is committed to engaging with and partnering with the industry, I would say, with more purpose going forward, you know, and recognizing that while we are obviously a critical stakeholder, we are more than that in this model. And so whether it is, it's literally the three people you saw sitting in the other panel who I have great confidence that they've understood the need to engage us differently and with more purpose going forward. And so I believe that will happen, and we'll be able to circle back with you all and affirm that.
Thank you. Could I have a follow-up?
Yes.
Very briefly. And I don't know if your agency or your organization would be the appropriate place or if it needs to be the health department, but on the focus on choice and competition slide that was previously shown, if there are some models that can show what the system would look like based on the multiple choices that are available. So if I picked number 4 from choice and number 2 from competition, what is that going to look like to the overall system? Because they both may limit competition, and how is that actually going to be impactful to the system as a whole? So it would be helpful to know what this actually looks like as we determine what the actual options are going to be.
Yeah, that's a great question, Delegate Austin. That is a place where I think the work is yet to be done through the regulatory working group. That's a place where we're going to be very interested, and they have noted on their work plan that this is an area that they will be focusing on. And so we will likely be a part of that process and can certainly keep you apprised of, you know, the hospital field's vantage point as the state starts to evaluate those options.
Delegate Gazzoni?
Thank you, Madam Chair, and thank you, panel, for a really nice presentation. Some of the challenges that you've described and talked about are true for many other industries or sectors. And almost all of those other industries and sectors are being asked to be more efficient with limited resources. Some of you know that I worked at NASA Goddard Space Flight Center for a very long time, and so I lived through the days of better, faster, cheaper. I know this is hard, and I want to always look for the upside. So could you share what you see might be the biggest or the best opportunities for the hospital industry or sector here in Maryland to drive cost efficiency as well as improve affordability for us all and quality? I know it's a really super easy question that I just posed.
No, thank you for the question, and I'll give you the answer through the lens of the medical system. Given our size, our scale as a system, we believe that there is opportunity to create more value, to create more efficiency by thinking and acting like a truly integrated healthcare delivery system, right? And that is different than perhaps many health systems grow up with the uniqueness of each community, and therefore the certain inefficiencies that come when you have the size and scale that we have. But we have been very purposeful over now going into our 4th year to drive a high reliability organizational journey as a system, which says how is it that you create the efficiencies and value by thinking and acting like a system. It will again, to your point, and I'm sure this happened where you were before, which is it means change. It does mean, thinking and acting differently as a delivery system. But the examples that we use is that when we think about cancer care, cardiac care, orthopedic care, mother-baby care, where are the efficiencies that we can gain and best practices so that we're not learning and reproducing at every one of our access points, models of efficient care, but we are creating a system. For us, that is a journey that we are on, but the value, the benefits will come from, again, as you say, we realize that we are being asked to do more with less, and we're not afraid of that. What we have to ensure, though, is that we are all aligned around what are the resources that are needed as healthcare continues to evolve. And so that is, to us, the work that's in front of us. But absolutely, I think understanding what are the expectations of how we act as a system when it comes to supply chain acquisition, when it comes to drug acquisition, what are the savings that we can get when we're doing, and we learned as a medical system a lot about this through COVID. We acted like an integrated delivery system through COVID when it came to purchasing PPE, purchasing drugs, creating healthcare delivery algorithms, when it came to HR policies, when it came to testing, vaccination. We acted like a system, and we believe that was one of the major contributing factors to helping not just our health system and our communities, but the state of Maryland navigate the challenges of COVID the way we did. And I believe other health systems in the state are in the same circumstance.
Thank you.
Delegate Rosenberg.
Thank you, Madam Chair. Dr. Sunta, I believe you touched upon this in response to the question from Senator Ellis. That is, what incentives can we provide to keep our skilled care providers, doctors, nurses, others, in the hospital system?
Yeah, thank you on behalf of the hospital. That's a critical question, because when you think about it, one of the things that I think Tequila described is there is a reality in the state of Maryland. Objective, again, please go validate this. Where is the state in physician reimbursement on the professional fee side relative to the nation? And I believe that when you look at that, you will find we are in the bottom quartile. We might be bottom decile as a state for physician reimbursement. That requires health systems to think about and invest in our physician workforce, and not just our physician workforce, our advanced practitioner workforce. So some of the things that I believe we as a state have to take on are we allowing our healthcare professionals to operate at top of license? Because by allowing them to operate at top of license, you expand a workforce. So that's an example of a body of work I think the state can take on. What are the incentives we have for loan forgiveness programs across the state of Maryland, and how robust are they to be able to say to people who come out of their education with significant debt that if you commit your professional lives to the state of Maryland will be there for you. Those are the examples, Delegate, that I would say are very tangible bodies of work that the state can take on, and the state benefits, right? We keep our talent in our state, and they become vibrant, active members of our communities by doing so.
Thank you. I will look forward to your testimony at my bill hearing. Thank you. Thank you.
You're welcome. Delegate Ross.
today to make the situation better for safety nets? And then part two, this model, do you think there's anything that was left on the table for safety net hospitals? Is there anything that got left on the cutting room floor that you felt needed to be considered for safety nets?
Okay, so I would say, again, within our health system, we do absolutely have safety net healthcare access points. And there's no question that they require differential investment. And they require differential investment not because they're inefficient in how they deliver care, but the healthcare needs of those who arrive at our doors in safety net healthcare circumstances are far more complex. Unfortunately, under-resourced communities, by the time they get to healthcare access, have a higher complexity of care required to be delivered, and that costs. And so the state, and I would say over the 5 decades of the uniqueness of the model of Maryland, it's been one of the hallmarks of the Maryland model is to preserve access, to protect healthcare access points that in other states are state and county-owned entities. Those costs fall to the state in every other state in the country. And in the state of Maryland, one of the unique features of the model is it's a shared responsibility. And so part of the challenge that we will have going forward with our federal colleagues is to ensure that they see that as valuable within the state of Maryland. And I think I know what I'm saying when I say that to you. That is not an easy conversation, but it's a critical one, because that is the only way, because otherwise, this conversation of cost shifting that you all are looking at that math, it's only going up. The only other way to solve it, it's not rocket science, is you have to shift that cost somewhere else. And if you shift that cost somewhere else, that's the commercial market. And one of the challenges we have that was highlighted is when you're a safety net healthcare organization, you don't have a commercial market to shift to. So it is only, in our world, a health system of our size and scale that can take that burden on. But that burden then falls to the rest of our healthcare delivery system in the medical system's perspective. So it is real work ahead. There is still work to be done around efficiency of care. It is where getting upstream in the population health investments and work that we have to do can also return greater impact. Because if we can do a better job of caring for people outside the walls of the hospital, then by the time they get to the hospital, one, there'll be a decreased demand, but they will also not be in the same medical circumstance, a clinical circumstance, when they arrive to us. But that's hard work because it connects back to, do we have a healthcare workforce willing to work in these communities? Do we have partnerships with other nonprofit organizations in those communities? And that's sowing a lot of nets that we are required to do in this model that goes beyond what we regulate, what we oversee.
Thank you, and thank you, Madam Chair.
Colleagues, this has been an extraordinary conversation, both from the table as well as among members. You know, we've had a great deal of high-level conversation, but I will ask both those at the table as well as those members, please remember the 3 Bs. Be bold, be brilliant, but absolutely be brief. Senator Lamb.
All right, well, with that mandate, that's great. Certainly share the concerns with this cost shifting. I'm not going to delve into it any further, but you know, a large chunk of the concerns with this additional costs and burdens being put on hospitals are, you know, the physician workforce underfunding. And I do have a bill that tries to address some of the workforce underfunding for emergency medicine physicians, which I know is something that, you know, all of you are cognizant about. And this question, I guess, in some ways was meant for the prior panel in the HSCRC, but from your perspective, what more can the regulators, the commission do to address this physician workforce underfunding? Are there specifics that can be undertaken by the commission to help address this, beyond just the legislation, for example, that we're putting in?
Thank you for that question. I think, You know, the most obvious opportunity is to recognize the costs that hospitals are incurring and to incorporate that cost in the rates that they allow hospitals to charge. So the statutory mandate that exists right now for HSCRC, we believe gives them that authority. However, I think they have a different interpretation. And so, you know, there may need to be some clarifications to the statute to ensure that they have the authority, they know they have the authority to be able to actually provide funding to hospitals. So that would be the most direct opportunity from a regulatory standpoint. In addition to that, though, I think the other place to look at is, you know, some of the root cause issues. Dr. Santha talked about the underlying reimbursement issues that exist. And so looking at options and approaches to address Maryland's low reimbursement. You know, I would say those are two key strategies that we could take to solve for that particular problem in Maryland.
And when, you know, I guess a lot of folks will say that, you know, physician reimbursement's not a thing, it's not a thing. I think Dr. Santha points out that we could very well be in the bottom 10%, I guess, when it comes to provider reimbursement.
Yeah.
And that's significant because that does affect access to care, whether it's in rural areas, you know, urban areas, underserved areas and the like. That's a very real problem that affects the ability of our constituents to be able to get care. Last question here has to deal with, and I guess with what Ms. Terry, you're saying, there's some difference in interpretation, I guess, with whether or not the commission has the authority to take into account workforce underfunding in their rate setting.
Correct.
You believe they do, they believe they may not.
Correct.
Yes, okay. Last question deals with down coding, because it is a concern that we've heard from a lot of constituents about. When you hear about whether it's 1 in 6, 1 in 7, 1 in 10, that's a lot of folks that are experiencing the effects of down coding. And so, you know, denials are really a way also to reduce access to care, right? It's just another mechanism to reduce access to care in rural locations, underserved and the like. What do you see as what regulators like the HFCRC can do to address the downcoding issue? Because we also have a bill dealing with downcoding.
Yeah.
And apart from the legislative side, I think there's some additional pieces that can be looked at from the regulatory end.
Yeah, and I think that's a place where we would love to collaborate with you to take a look at the bill language and, you know, actually work with HSCRC. To their credit, they have been very open to looking at strategies that they can take on to help address denials. They have been running a data work group to look at ways to collect information on, you know, what denials are happening. And so I do give them a lot of credit in this area that they're working very collaboratively with hospitals on this. I think that, you know, downcoding is a complicated issue, sort of hard in some ways to tease out from claims data. So I think we have to sort of work together with you to maybe refine some strategies in that area. But I think another thing that comes to mind is there is the adverse events work group that was established in legislation. You know, really getting some movement in that group would be helpful to, you know, bring people together and start to address some of the issues that were part of the mandate of that group. I think it's been a little bit of a slow start, and I think it's a really important opportunity for us to work collaboratively, again, across the healthcare spectrum on strategies that can address those issues. So I'd say those would be two ideas to consider.
Okay. That's helpful. Thank you.
And I'm going to piggyback on what you just said, Ms. Terry. First of all, I also want to say thank you for the presentation, but also for all the service you provide. As someone who might be considered a frequent flyer, I can only speak to the high quality of service I've been getting in Maryland hospitals. But I want to follow up, and this, I'm just going to ask for information. I don't expect an answer now. When I look at your headwinds, there are a couple things that we have to adjust for, that we can't change. The demographics we can't change. The federal, you know, changes, boy, do we wish we could change them, but we can't. The denial piece, we as you just said, we can have impact on that, but we need granular information on what it is, and I was glad to see that you broke it out by inpatient, outpatient, and the third one, ED.
Emergency department.
But I would love to see that data broken out by category. Was it the medical director denying the service based on plan design? Was it an error that the carrier made? Was it an error that the submission made? So if you could break it down that way, and also break it down by, was it a commercial carrier? Was it Medicaid? Was it Medicare? What was the entity that made the denial? That would be really helpful to us as we think about policy that could help improve that. So I would thank you for that. Delegate Hill, I'm going to go to you, but I'm going to remind you that we have a meeting at 4 o'clock. So I'm going to ask you to be brief. Forget about the bold part. Just be brief.
Is that so? No. So thank you, and Ms. Terry especially, thank you for always making things simple and giving us bad news with a spoonful of sugar. Dr. Sumta, here's the question. We can do it offline, but I really wanted to ask it here and hope you can answer quickly. So you talked about we need to have true integration of our systems, not a single system maybe. But what about the other things we can control? We see, I mean, in my last 40 years, there's always hospital construction going on. Whether it's a beautiful lounge with a piano bar or whatever. There are components to that. So what do you envision the hospital, you said this is an opportunity moment, what does the 2035 hospital look like? What is a 2050 hospital, and when are we going to shift some of the resources that we do into making these castles into something that's practical, is respectful to the patients who come through, but also respects the fact that we're not delivering care maybe in the future in the hospital the way we used to, when more care is being done in the community and at home?
I invite you to come visit us down on the Eastern Shore and see what we're building. I'll invite you to come to Prince George's County and see what we built most recently, because I think those are two fine examples of not thinking about the historic way healthcare has been delivered in hospitals, but far more importantly, thinking about exactly what you're describing, which is the care continuum is changing, and healthcare access points are changing, and hospital-based healthcare access points are changing. But I will certainly take that offline, but I'm not joking when I say, please, I think we could learn something from showing you what we've done and what we are building right now on the Mid-Shore that defines how we think about the future of delivery. Thank you.
Okay, thank you very much. Can I add one thing to my list of things to measure? How many were overturned? So what percentage of them were ultimately overturned? With that, thank you very much for your presentation. Oh.
I have one more
Hayes.
question. Yeah, thank you, Madam Vice Chair. Senator Mouse.
Thank you, Mr. Chair. I heard Eastern Shore, so my ears perked up. This would be very, very quick, and I know this has been a very long hearing, but it was something I was going to ask, I wasn't going to ask, and then it came up. But, you know, looking at all these changes and all the things we're discussing, Dr. Sumta, do you, what are, I mean, we're very concerned, you know, we want to make sure that project stays on time and everything goes, you know, because of the situation I mean, it's a tough situation right now. How, does the head model affect that new building that we're putting up and all we're trying to do on the shore? You know, I mean, we've got very limited services and a lot of things are strained. I just want to know if do you have any concerns about the mid-shore area and how the head model, if it, you know, what should be our concerns?
Appreciate the question, and I'm going to tell you, I actually think the Mid-Shore and what we're doing in rural healthcare is an opportunity for the state of Maryland. I think the Secretary, the Executive Director of Rate Commission have been phenomenal partners in helping elucidate to the federal government how the state of Maryland and this model is actually an important tool in solving healthcare resources for rural healthcare. And so my hope is that we actually we use the Mid-Shore to bring more attention to the federal government. When you think about rural healthcare, I will always say is we're teaching the nation about rural healthcare transformation as a consequence of the model of, I believe, our health system, the state of Maryland's commitment to it, there is a unique opportunity that I think we have to ensure that we take advantage of. To your point, we got to be on time and on budget with that building.
Well, Delegate Hutchinson just came back, and, we are, that project is so important. As we go through, we had a question earlier about, task force meetings, session being out, that sort of thing. That is critical to us, absolutely critical. So as this goes along, please stay in touch with us, because we want to make sure you have all the help that you need, particularly with that particular project.
Thank you.
Thank you. All right, there's no more questions on this side. I just want to say thank you to our panelists, thank you to our committee staff and all of the members here for a really important conversation. As we go through this legislative session, I think some of the themes echoed here today will continue through some of our deliberations. It's always good to be back home with, formerly HGO, now in the Health Committee, where I cut my teeth here in the legislature. But thank you all so very much. I'll turn it over to Vice Chair Collison.
Thank you, Vice Chair Hayes. And so we do have a second area that we are going to be talking about. So we're going to call up now on relative to emergency department wait times. Would Secretary Seshomani and Dr. Crum return to the hot seat, please? I'm not going there. Thank you very much for your patience and stick-to-itiveness.
Madam Vice Chair, Mr. Vice Chair, thank you so much for bringing us back up to talk about another really critical issue, an important issue facing the state of Maryland. I will keep my comments as brief as possible. Not my strong suit for sure, but I'll give it a shot here. I want to follow Dr. Santha's lead, right? I'm also a glass half full person, and I want to talk a little bit about some of the improvements that we've seen in ED length of stay, some of the work that's been done to improve ED length of stay, and then also importantly talk about some of our opportunities, because this is something that, as you all know, is so important for patient experience and for the performance of hospitals, and very importantly, it's a key access point, right, for patients here in Maryland. So let me start very briefly with just a recall back to the beginning of our first panel, where we talked about the priorities of the administration and really thinking from a whole system perspective, right, where we can improve our healthcare delivery system to be world-class. One of the key kind of areas of focus, metrics of focus, is ED length of stay within that, right? It is an indicator of how healthy is our system as a whole. It's not the only indicator, but it's an important indicator. So let me start with where does the most recent data take us, right? Let me call out a couple things here. So overall, the preliminary data through November 25, so I'm talking about 25 over 24 performance, is that there's some modest statewide improvement in ED length of stay. But what I want to highlight here is that we have seen over the course of the last year a number of hospitals, more than half the hospitals, drive significant improvement in ED length of stay. I'm going to highlight a couple of the things that we've seen as movement, right, within the hospital industry, due really in large part to the efforts of the clinical operations teams who are doing great work and putting a lot of focus on ED length of stay. So we've seen that important precursors to ED length of stay, like left without being seen, door to provider time, ED boarding times. In many of our big systems in particular, we're starting to see real good movement on those precursors to both ED length of stay improvement as well as patient satisfaction movement. And that's in large part, and I'll talk about how we know this in a moment, but it's in large part due to the good work that those teams are doing to adopt best practices in moving clinical operations within their hospitals. That being said, statewide ED length of stay remains challenging, and so it's really important that we as a state take a holistic view, right? Because as those EDs and as those hospitals improve the efficiency of their operations, that's great. That's going to give us some lift, but there are many kind of whole system factors beyond that that we're focused on, and I'll talk about a few of those in particular. First, again, this is an area of focus for both MDH as well as the HSCRC. Let me turn to the Secretary to highlight some of the things that are going on at the department.
What'd I do? Okay. So yes, as Executive Director Crom mentioned, this definitely is a whole of government and whole of like the health system approach. And at the Department of Health, we've given you here some examples of some of the work that we have been doing that I think lay the foundation for where we go from here. And in particular, we know and have heard from our hospital partners about the issues of behavioral health and how where you don't have opportunities to divert away from the ED to more appropriate settings of care for behavioral health, that leads to significant issues in our emergency rooms. And so several of the areas that you see here, for example, supporting behavioral health crisis care, having community resources available to the ED to be able to safely discharge people with behavioral health needs, our community-based care in behavioral health. Those are all examples of where we've really been focusing there. In addition, and I'll come back to one of the things we talked about when we were last up here with you, where we can really focus on primary care and prevention, because where we can keep people healthy, then we can help them to stay out of our emergency rooms. And where, when we have good supports in the community, then you can safely discharge patients who have been admitted. And I think here one prime example is our vaccination programs. And I know we're working very closely with our hospitals. In addition to what Executive Director Crom mentioned about providing that respiratory surge funding, also working very closely to make sure that we are supporting people in terms of getting vaccinated so that they don't end up in our emergency rooms. And the last area here is around our data sharing and how important it is that we have the data that's available, both so that we can all know where more resources and services are needed, and so that people know where they can send people to, as being really important. The healthcare system is difficult to navigate, even for those of us who are in the healthcare system, and I think that's something that the department really takes to heart as we are thinking about ways that we can support everyone to be able to either help those they're caring for to navigate the system or to help patients themselves. I'll turn it back to the Executive Director.
So again, the HSCRC has done a number of things over the last year that are starting to bear fruit in terms of ED performance. I would again highlight the respiratory surge policy. We've already talked about this, but again, that's recognizing that unanticipated volume of respiratory patients to the EDs are a major stressor on the staffs the hospital staff that are treating those patients. ED length of stay measures, right? So we did restore ED length of stay as a quality-based reimbursement measure. It puts focus on ED length of stay when it's part of the quality incentives within the hospital global budgets. That's been in since 2024. And then also part of that is developing an ED length of stay really dashboard based on data that we're collecting from hospitals. So that'll give us better kind of line of sight as to the puts and takes of what are the drivers of excess ED length of stay. ED and hospital throughput best practices. I want to highlight this because it is a different approach that the HSCRC has taken in terms of partnering with hospitals to move this particular issue. We created in partnership with the hospitals, really a collaborative, right, to look at ED throughput best practices. That group really zoomed in on hospital throughput issues as a major driver of ED length of stay. I'll come back to that in a moment. At this point, all hospitals are participating in the collaborative work. The HSCRC has made it a requirement that that hospitals identify 2 best practices and then provide some additional data reporting and ongoing analysis. Again, this circles back to line of sight into where are the operational improvements bearing fruit. And then additional policy development. I highlighted some of these things, but certainly thinking about our approach to inpatient length of stay. I'll come back to inpatient length of stay in a moment as well, because that is a major factor here. The other thing that I would highlight here is that global budget carve-out. That is an area where we have heard from our clinical partners across the state, as well as from our own data, right, that part of the challenge here is ensuring that we have enough kind of capacity to manage high acuity, complex cases that come into the hospitals. These cannot be managed at other facilities. They have to be done at hospitals. And we need to make sure that there's enough capacity, because in some of our community hospitals, part of the driver of inpatient length of stay is because they can't transfer those patients in a timely fashion to a place where those complex cases can be handled and managed, right? So that global budget carve-out we see as a critical piece of the total puzzle. Want to also highlight the Maryland ED Wait Time Reduction Commission as well. We're in midstream here. As a reminder, we did an interim report that gave a directional sense of where the recommendations are going. What that commission is accountable for is a concrete set of recommendations for improving ED wait times by the end of the year, and we're making progress there. The reason that I want to highlight that work is because it's really given us, I think, a really collaborative effort and collaborative focus around a model, a theory of change that makes sense for moving ED length of stay. And that's reflected in the priorities that the commission has gravitated toward. One, the first 2 I'll highlight as important data work, and I think in this case, data is really a critical underpinning of the actions that we're going to take within the state, because for the longest time, right, historically, we've not had good, comprehensive, holistic sense of all of the drivers of ED length of stay. And so, let me talk for a moment about what that means. The theory of change that's really materializing within this group is this. Most of the ED length of stay is driven by ED borders, right? So these are patients who are staying in the ED for beyond the point at which they've been seen and diagnosed, right, by a provider. They are awaiting either admission to an inpatient bed, or they're awaiting a transfer, or they're awaiting some other type of discharge, right, or transition of care, right? So we're seeing that as a major driver of the total ED length of stay, right? Because it takes ED beds offline, right, for those emergency department beds. Then we look at inpatient length of stay, right? So inpatient length of stay within our hospitals, it's not a shock, right, that a lot of the biggest movers in terms of reduced ED length of stay are the ones who are driving improvement in inpatient length of stay across the state, right? That there's tight correlation there. That's really important because, again, then the folks who are boarding in the ED can move up into the inpatient bed, right? And then the final piece of the equation is something that we're putting a lot of focus to. Where are the transitions of care that are creating the biggest bottlenecks, right, for that continuum? What this group is really gravitating toward is seeing that the highest growth in inpatient length of stay is really on those patients who are being discharged to post-acute settings. That was mentioned in the previous panel, would completely agree with that. So looking for kind of multi-pronged efforts, right, to how can we improve that kind of transition of care to the post-acute settings. These are the things that are really going to create big gainers in ED length of stay, even though in many cases they are not contained within the emergency department, right? In some cases, they're not contained within the hospital at all, right? So these are the areas of focus for that ED Wait Times Commission. And then I would flag continued focus on adoption of hospital best practices throughout the state. Again, we're seeing early returns here as you know, hospitals improve their kind of precursor metrics to reduced ED length of stay, but we need to sustain that focus, and I think there's a really good commitment, and I think you'll hear from other panelists as well. There's really good commitment on that piece, and we're looking to get concrete traction on some of these other areas related to inpatient length of stay. Just to highlight, you know, why do we see discharges to post-acute as being, you know, a big gainer, potential area of opportunity for us? You know, when we look at inpatient length of stay, the outlier here for us, and it's statewide opportunity, so this is not specific to one hospital or another, is really in these inpatient length of stay for patients who are discharged to post-acute settings relative to national norm, right? So this is not relative to other inpatients, right? This is inpatients of the same type across the nation. We are really challenged as a state. So this is where we're seeing a lot of opportunity for focus as we move forward here. So let me pause there, and you know, ran through that quickly, but I'm happy to take questions here.
I have Delegate Kaufman.
Yes, thank you. Returning to patients, and because the hour is late, if you could get me this in writing, either one of you. I'm afraid that with, and thank you for your commitment, first of all, to get people a bed faster, because I was on a gurney once for 13 hours in the ER while I was waiting for a bed. But I think that the gains that we've made have the potential to fall away as a result of the One Big Beautiful Bill Act, because instead of getting people's strep throat and ear infections taken care of at urgent care or some other entity, the people will no longer be able to afford their insurance, so they'll come to the emergency room. So my question is, what are you going to do to assist hospitals, because they're going to get a new influx of patients once work requirements come in on December 31st, 2026, et cetera, to ensure that they have the support they need to handle the influx without losing ground on our efforts to reduce emergency room wait times.
Thank you so much for raising that and for connecting those two issues. I think first and foremost, our goal at the department is going to be to implement HR 1 in a way that keeps as many people who are eligible for Medicaid on Medicaid. When you are creating new, new processes around determining eligibility, how can we make those processes as streamlined and easy to navigate as possible so that we can maintain coverage for people who are eligible? The second thing is seeing the opportunities in some of these changes. We talked in the last panel about the healthcare workforce and about the shortages and the opportunities there. And coming back to what Senator Motz had asked about with the Rural Health Transformation Program, we now have millions of dollars that we can invest in workforce development, which can enable people to then work to help them meet work requirements for Medicaid as well. So again, I think our first priority is really to make sure that the people who are eligible for Medicaid can stay on Medicaid, and making sure that we are leveraging all of our tools to address the issues that are present in our healthcare system and our economy, which then can again also make sure that people stay covered so that you don't end up with this vicious cycle with uncompensated care.
Senator Lamb.
Thank you, Mr. Vice Chair. Just one question for you, and this is for Dr. Crom. I think, you had in here in one of your last slides the standardized bed capacity, and I've heard from a lot of folks also about the problem with boarding, and then the, I guess additional concern too with adequacy of beds, right, inpatient beds in units, and whether there needs to be a new look and reform of our certificate of need process, which has been longstanding, probably hasn't been adjusted or accounted for, and changes in many, many years, if not decades. There were no specifics in this. Is this still something that the work group is looking at? Is that why there are no specifics here? Or at what point can we expect something to come back on this?
Yeah, so that's in progress, right? So this year is the year where we're going to deep dive into a couple things, right? One is modeling out some of those capacity challenges around the state. So I'm speaking for the ED length of stay, or ED wait times commission here, as well as what are the kind of concrete solutions, right, for driving some of that. At the HSCRC, some of the work that we're going to be doing is looking both in terms of work on inpatient length of stay. What is our approach to improving inpatient length of stay? Obviously, optimizing the beds that we have is really critical. But then I would also say I'm happy to come back with the MHCC and talk a little bit more about the CON process. I think one of the things that I spoke about last year when we talked about ED length of stay. There are places in the state that where the number of beds needs to grow. I think there are a couple things. I mentioned the carve out. I think the hope there, right, is that some of those beds that are required to do that delivery of complex care will be generated through that process, right? But there are other things that we have in flight in our policy calendar that I think would address capacity and access issues. And really, the lens that we're looking at, viewing that from is that of access, right? And equitable access, across the state. So I think that's a really important aspect of the work that we have in front of us over the next year.
Okay, thank you. I would urge some expediency to this. This is a work group that's been established since July 1st, 2024. We're now January 2026. This is a problem that's facing all of us in all of our districts. It's a very real problem. There's no reason we should be at the very bottom, if not close to the bottom of states when it comes to ED wait times. So we really need to move this quickly. It's been a year and a half, and we need some recommendations.
Understood.
Okay. Delegate Bandari.
Oh, thank you. Health issue like ED wait time still follow me. I want to thank Madam Secretary in SCRC, Jonathan, and all the stakeholder, and also who serve on the Emergency Department Wait Time Reduction Commission, and would like to acknowledge Madam Bidel, Madam Speaker, for their leadership. And I had a pleasure, visiting Tidal Health in Eastern Shore and many others during the interim to see the effect of the ER wait time bill that we passed. The data in our visit shows progress is possible, but uneven, and much of it depends on voluntary participation. Given that key drivers of ED wait times are systematic and beyond any single hospital control, I'd like to ask our department, what tools does the state currently have to ensure coordination and sustained improvement statewide? Also, that we can't forget, like close to 200,000 Marylander residents may lose Medicaid when cuts and eligibility changes that will be in full effect sometime between July 2026 and June 2028, and we will have more of the patient coming to our ER wait time, hospital.
Yeah, I'm certainly happy to take that question. So I'd say there are, one of the aspects of the multi-agency working group that I think is really cannot be overstated is the fact that we are trying to combine the tools of all of those agencies and bring them to bear to these types of whole system problems, right? And so when we think about, we've already mentioned some of the tools that are going to have to be aligned, and then through the data work that we've been doing, how much of that is accretive, right, to improvements in ED length of stay. So I'll mention a few of them, right? Primary care investment. We've mentioned that several times here, where primary care really is the appropriate access point for a lot of the patients who seek care in the emergency departments. Looking at some of the tools around CON, et cetera, certainly, I think, appropriate to look across agencies. Some of the quality work that our agencies do, whether it's MDH or HSCRC or MHCC, again, aligning toward improved health outcomes, which then improve ED length of stay, right? So really, I think as we move forward, we do have a lot of tools in the toolbox. Where I think we have work in front of us, and it relates in part to the AHEAD model, is there is opportunity to align other parts of the healthcare delivery system through value-based programs, right? We've done some of that work. I referenced EQIP. There's potential to do more of that work. Dr. Santa referenced it before, right? Part of the goal here, right, is to drive population health improvement. That is materially linked, right, to ED length of stay. And we have that opportunity in front of us. We have to do the work so we have work in front of us to realize those opportunities.
Thank you.
Thank you. Delegate Taveras.
Thank you, Madam Chair. I'd like to first say thank you in realizing improvements at Adventist White Oak, which is services individuals in my district. It would be interesting to see what particularly were the improvements But the question that I have for today is where are we with the pediatric overstays that have occurred, where there were some concerns regarding the fact that there were.
Delegate, we're going to have another briefing on that another day, so if you can hold that question.
Okay,
Is
that's
that okay?
fine.
Okay.
That'll be great.
Thank you for your understanding.
Thank you, thank you.
Okay, thank you both very much again for staying and for the information. I'm sure we're going to be talking about this more, and I appreciate it. And I'd like to ask Patrick Carlson, Andrew Nicholas, Dr. Ahmed, and Dr. Vibhacker to come up on behalf of the Maryland Hospital Association. And who'd ever like to start? Thank you.
Well, good afternoon, Vice Chair Cullison and Vice Chair Hayes, members of the Senate Finance Committee and House Health Committee. I'm so glad to be here with you today. Thank you for the opportunity to share an update on the efforts underway to improve wait times and lengths of stay in our hospital emergency departments. I'm Patrick Carlson, the Vice President of Care Transformation and Finance for the Maryland Hospital Association. And joining me today are Andrew Nicholas, who's our Senior Vice President of Government Affairs and Policy, and then we've got Dr. Shafiq Ahmed, the President of Johns Hopkins Howard County Medical Center, and Dr. Neil Vibhacker, the Associate Chief Clinical Officer at the University of Maryland Medical System, and member of the Emergency Department Wait Times Reduction Commission. So many of us have experienced the challenge of a health emergency, whether for ourselves or for a loved one, and have confronted the difficulty of having to wait to be seen and receive care in a hospital emergency department. ED wait times and lengths of stay have been a long-standing challenge in Maryland, and these challenges have come even more into focus in the COVID and post-COVID years as we continue to experience difficult surges of respiratory illness that require many Marylanders to receive hospital care. While we are encouraged to see improvement in wait times at many of our hospitals in 2025, we recognize that there is still more work to do. So with our time today, we'd like to speak to current hospital and state policy initiatives underway, provide an update on efforts of the Emergency Department Wait Times Reduction Commission, and hear from our hospital leaders on their work to tackle the challenge of wait times and length of stay. So wait times and length of stay are impacted by factors throughout the healthcare system. And to be successful in optimizing care and improving what patients experience in our emergency departments, we need stakeholder collaboration and align efforts through a multifaceted approach to achieve sustainable improvements in patient care across the healthcare continuum. Hospitals must implement strategies to improve factors within their control, such as improving processes for patient flow, admissions, reducing bottlenecks, and discharging patients when there's an available placement option. We need well-designed and impactful regulatory approaches that will help to improve ED lengths of stay. And we also need important interventions outside of the hospital environment, such as enhancing access to primary care, urgent care, and community-based resources to reduce unnecessary ED visits and improve patient transitions. So now to turn to some of the hospital and state policy initiatives that are underway to address the challenge of ED wait times and lengths of stay. Hospitals are working to improve the process of care within the areas they can influence. This starts with input, where patients enter the hospital care system, and it includes everything that happens in those first critical moments, getting patients off ambulances, determining how sick they are, and starting the care that stabilizes them. And then hospitals are also focusing on improving throughput, which are approaches within the acute hospital care cycle to reduce inpatient lengths of stay and support timely care transitions for patients from the ED to an inpatient bed. And lastly, hospitals are working on output, which are efforts to successfully support transitions to care beyond the hospital setting. And this can include spotting early which patients are likely to go home soon, organizing discharges early in the day to improve bed availability, and using discharge lounges so patients have a safe, comfortable space where they wait for transportation or final instructions. These efforts can make a difference, but hospitals need help from other partners to address external factors that delay hospital discharges and lead to individuals using the emergency department as a source of primary care. So our Maryland state agencies and regulatory bodies are uniquely positioned to influence improvements across the healthcare system and are advancing several policies to improve the continuum of care. And there are a couple of important initiatives that I will highlight. One is one that you've already heard about, which is the ED Hospital Throughput Best Practices Policy. Under this HSCRC policy, our hospitals are committed to implementing identified best practices to improve patient flow and enhance coordination between emergency department, inpatient, and post-acute services. This has been a collaborative process, and we're encouraged with the important gains that we're seeing already. The other is the surge policy. You know, we continue to see each year surges of patients with respiratory conditions requiring hospitalization, and this year's surge has been especially difficult due to influenza A. And HSCRC recently approved additional surge funding for the current fiscal year, and our hospitals appreciate this action as it will support hospitals in maintaining essential access to life-saving care during periods of extraordinary demand. So with that said, I'm going to turn this over to my colleague Andrew Nicholas, who will talk about the Emergency Department Wait Times Reduction Commission.
Thank you so much.
I'm sorry, Andrew. I have to apologize on behalf of many of the members of the Health Committee. We are going to need to leave for a meeting. We will continue to listen, and we have you on tape, but I would ask that the Senate finish up, and I sincerely apologize that we won't have a time to interact in this setting, but I promise you that all of the members of the Health Committee will be in touch with you with questions and information. So thank you for your understanding and your patience.
Absolutely, and I promise you all this will not be the last time you see me this session, so I will be around. And I completely appreciate that, Madam Vice Chair and members of and Mr. Vice Chair, members of the committee. Thank you all so much for having us here to take part in this important conversation. We know this is a critically important issue, and we know that it affects all of us, and we know that it must improve. As Patrick said, hospitals continue to lean in and will continue to lean into internal process improvements, but we are also engaging beyond the four walls of our hospitals. And one of the ways that we are doing that is through the Emergency Department Wait Times Reduction Commission. In light of the time, I will endeavor to not be repetitive to what things you've heard already, but you know that this was established. I was going to give Delegate Bandari a shout out. He was the sponsor of the bill that created the commission, so in absentia, thank you, Delegate Bandari. I am privileged to serve on the ED Wait Times Reduction Commission, but I want to be clear, I am not here in representing the commission in official capacity. I am representing the Maryland Hospital Association. But I did want to share, we can go to the next slide, just some of the work that's been done by the commission to date, because I do think it presents a unique opportunity to really drive change for this issue. As the Executive Director Crom mentioned at the previous panel, the commission put out an interim report. In that report, they noted several unique factors with Maryland hospitals. Now, these are in no way meant as any excuses or justifications for patients experiencing long times in the emergency department. However, it's important to understand some of these things as we grapple with solutions to this issue. And I'm not going to go through all of these, I'll just highlight a few. First, Maryland hospitals are in general larger and serve more patients than their counterparts across the country. And that's both in the emergency department and in the inpatient space. Also, Maryland has a proportionally high number of academic and teaching hospitals. Now, this is a great thing and an invaluable resource. Obviously, these institutions develop the future workforce and train our providers, but they also serve our most complex patients with the most severe illnesses, often requiring more intensive care, and which takes more time. The last one I'll note is that Maryland hospitals are also grappling, as has been mentioned, with significant resource gaps in the post-acute care space. Those gaps lead to bottlenecks within the hospital, as Executive Director Crom mentioned, and that is a real challenge facing Maryland hospitals. We can go to the next slide. So, as the commission did put out an interim report last fall, and that report did develop a few recommendations that are going to guide our work over the next year as we develop concrete policy proposals. And the first one was mentioned, but I want to just kind of highlight it because I think it's critically important. It is critically important as a state, we undertake a comprehensive capacity assessment of across all healthcare settings. So that's preventative care, inpatient hospital care, behavioral health care, post-acute care, understanding where we are and where we need to be in order to meet the demand for care in the community. Because that's about right-sizing. We must right-size the capacity in each of these areas to enable our patients to access the healthcare continuum where they need to. Because if a patient is not able to do that, if they're not able to get their primary care appointment or they're not able to get their behavioral health care appointments in their community, they are going to end up in the hospital. And we will be there to serve them. Our President and CEO says our folks boot up and suit up every single day to serve our patients, and that's absolutely true. But we don't want patients to have to come to the hospital by default. We want to develop a system that is able to serve the patients in the most appropriate setting. And so undertaking that work to understand where we are and where those gaps are is critically important. The Commission will also be able to model and test out policy proposals so that we will understand their impact on this issue, because we all know it's not going to be one thing that addresses it and fixes this problem. It's going to be a combination of several different proposals that come together to really move the needle, and so it's critical that we understand what those impacts will be as we form our recommendations. And lastly, the Commission's really leaning in to developing a formal policy proposal to improve post-acute care access and capacity, a well-documented issue across our state. And so, next slide, please. And so I think you've kind of picked up a common theme here. This effort to address this issue really does take all of us. It takes all of our providers across the continuum of care. It takes our regulators, takes you as our legislators, all of us working together to try to really drive change. And if we go to the next slide, I've highlighted a couple of the factors contributing to this problem that I think really highlight that need for collaboration. The first is the need to expand access to preventative care. Ensuring folks can get care at their primary care and urgent care is critically important to make sure that their underlying illness does not get to a point where they need hospital care. And this is a problem, as has been mentioned, that we'll need to watch even more closely as we see the impacts of H.R. 1. Addressing rising rates of payer denials. You've heard that from the previous panels on the model. This is a significant problem for hospitals across the state. Denials continue to rise. They cause delays in care, cause people to forego care altogether, which doesn't mean forever. It means they're going to come back with a more serious condition. And it takes doctors and providers away from the bedside. Addressing that issue is critically important. Many thanks to you, Senator Lamb, and to Delegate Gazzone for sponsoring a bill on that issue this session. Look forward to working with you. And again, you will be hearing more from us on that issue throughout the session. And then back again to expanding post-acute care access and care coordination. That is going to be a challenge, critically important, but I am hopeful and optimistic that there could be some low-hanging fruit on the care coordination side while we lean into expanding the overall capacity. And so with that, I'm going to turn it to some of our healthcare leaders in the state, starting with Dr. Shafiq Ahmed, the president of Johns Hopkins Howard County Medical Center.
Great, thank you very much. I really appreciate the opportunity to present to this esteemed group. I'm Shafiq Ahmed. I'm the president of Johns Hopkins Howard County Medical Center. I'm going to do a couple of things. I'm going to keep it fairly brief, but I do want to set, first of all, what our hospital is. I want to set what we have been doing about this issue, and then concerns and challenges that we have going forward. Next slide, please. So just to give you a perspective, we are the only hospital in Howard County. We're about 253 beds. On a regular basis, we are greater than 90% occupied. This has been a consistent issue for us for years. Ever since I've been at the hospital, about 10 years ago is when I started, and I came from Massachusetts. So it's a very busy hospital. When we take a look at some of the numbers, next slide, please. And services that we provide. We are a full-range hospital. We have orthopedic surgery. We have general surgery. We provide a lot of stroke care. In fact, we deliver some of the highest numbers of the clot-busting drug, TPA, within our health system. We have a fairly busy labor and delivery. So a full range of things that we offer. Next slide, please. But when we look at the numbers and you take a look, I would ask you to take a look at the number of ER patients that we see, and this is from 2024, close to 74,000 patients. When you look at this in respect to our health system and look at it with respect to the state, we are in the top 5 for emergency department visits within the state. And for a 253-bed hospital, that is significant. Johns Hopkins Hospital is 4 to 5 times the size of our hospital and sees somewhere in the 80s. So it's a pretty significant amount. What I like about this is patients really trust us. They want to come and see us. But the challenge is, are we right-sized for the emergency department demand that we have? Next slide. So really, when we took a look at these issues of the total demand and volume, the issues that my colleagues have talked about that buttress the issue of the acute care hospital, primary care availability, behavioral health availability before you get to the hospital, post-acute availability after the hospital, really puts pressure on the hospital itself. And as many people have described, this is not simply an emergency department only issue. It's a whole hospital issue, and that is how we are approaching it. When we look at the size of our hospital since 2010, the population has grown by 18%, but that was the last time that the hospital actually expanded to accommodate any of those changes. Next slide. So we approach this from 2 angles, and one being behavioral health and the next being boarding patients in medicine. So from a behavioral health perspective, what we realize is probably 18 to 20% of the visits in emergency departments are behavioral health related. And we had a behavioral health unit that is within the emergency department. That is not to be confused with the inpatient unit, which we have one as well, but this is the one where patients come in and they would get a evaluation to see whether or not they need to be admitted or they may go home. We also take emergency petitions from law enforcement, so we are getting all of these patients. That space was originally designed for 6 patients at 1,500 square feet. Easily out of date, and in terms of numbers, we see 11 to 12 patients a day, and so that was definitely not taking care of capacity. The majority of those overflow patients were going to the other bays within the emergency department. This is a 36-bed emergency department, and so when those patients stay there, they have a longer length of stay, and that was preventing a lot of our other patients from getting the care that they needed. So our endeavor was to use another space in the hospital to expand the behavioral health unit, and so we went from 6 spaces up to 24 spaces and close to 7,000 square feet. A much more modern facility in comparison to what we had before. Definitely a big change for our mental health population, but what we were allowed to do with that was to retrofit within the emergency department a space for the patients with medical concerns. Next slide, please. And so we call that the purple zone, and essentially that is for patients that are not the highest acuity, they're not the lowest acuity, but somewhere in between. So we created 9 treatment spaces for that, and by using that space, we now see about 30 patients a day that go through there. Typically, we'd see about 150 patients total in the emergency department per day. So a good chunk of them have gone there, and we have seen results from this since we opened this. We've reduced the length of stay for a discharged patient, someone who's going to go home, from about 4.9 hours to about 4.1 hours by using this space. So this is segmentation, we call it, being able to see lower acuity treatments in a space, and that was one of the main concerns. So by addressing behavioral health, not only do we address a space for our behavioral health patients, but we also address for our medical patients as well. When we talk about our pediatrics, of which we have a separate emergency department, we initiated about 6 months ago what we call quick care to be able to see patients with lower acuity at the same time as patients with higher acuity. And that is one of the challenges for our staff because they always prioritize acuity and triage patients, but we were able to get them to build a space within their area to address these patients. And so they've had a significant reduction in the wait time and a big increase in what we call the likelihood to recommend score, meaning patients' appreciation and their patient experience when going through this. Another thing that we did was addressed the patient discharge lounge, which you've heard is a best practice. This is actually nothing that's new. This has been in the industry for years, but it's very hard to implement and it's very hard to maintain. We have been fortunate that we've gotten some help from the MHA and our county as well in some funding for about $200,000 to help fund this unit. We see about 30 patients a day there. And so addressing the length of stay for the entire hospital, this is a great opportunity for us to be able to get patients who are going to be going home, not our skilled nursing type patients, but the ones that can go home, to come to a space where they can get discharge instructions, maybe coordinate other types of care. It's been very popular with them actually, and so we've been using this as well to address the length of stay for the hospital. Next slide. So really, this brings us to the big issue that we've been talking about, and that is boarding patients. So to give you some perspective, a 36-bed emergency department, after COVID, we began to see an average of about 30 patients that are boarding and waiting for a bed upstairs. And it's not like our length of stay was very high. We averaged probably about 4.4 days for people to stay in the hospital, and it's actually on the lower side. But again, some of the issues are really mechanical in terms of when the demand is there, when patients need the bed versus when people are leaving the beds. And so we are focused highly on processes to make these things happen, but process alone is not going to take care of it. And so what we realized is we have a capacity issue that we need to address. And with that, we were planning, and we actually have broken ground on a 29-bed observation unit to get observation short-stay patients care in that space, so they are less likely to be boarding in the emergency department. Now, I'm very thankful to all of you because of the MHA bond program to help with the funding for this, and I'm very grateful to our county executive and our county council for having the forethought to help with our capital. One of the big challenges that I wanted to talk about also was with the challenges with the upcoming AHEAD model, with decreased pressure on margins, our hospital has had a negative margin since COVID. And so to be able to save for capital and to be able to do these projects, it's not likely that that's going to be addressed. And there is no separate capital program at that rate because these aren't super large capital projects. In fact, this observation unit is about $25 million. But the county was able to give us funding that helped. We had philanthropy as well that raised over $5 million, but they committed over 3 years about $15 million towards this project. And similarly with the behavioral health unit, that was a $10 million project, and they committed $2 million. And again, the MHA bond fund was used for both of those as well. But that is not necessarily sustainable for hospitals, as has been mentioned by my colleagues before. Age of plant is an issue. Our hospital is appropriately taking care of the capacity that they have for the communities that are growing, that are around them. And so that's the one thing that we address. So hopefully once this is open at the end of this calendar year, we will begin to see a much bigger decrease in boarding times. Already with the processes we put in place, we have a daily, almost every few hour focus on these issues. We have seen a decrease in the wait time, in the length of stay times for our current observation unit. Last year, around the same time, we had about a length of stay that was about 31 hours. We've reduced that to about 27 hours. These may not seem like large numbers to you, but for us, they're pretty significant. That shows that we are committed to the processes to make these happen, because simply building another unit and creating another parking lot is not our goal. We do want to focus on length of stay significantly to reduce that as well. So our infrastructure has to change, which is what we are doing. We have to be able to afford the operations of this, and so that is why we're going to work with HSCRC to ensure that we can do so in the manner that actually addresses our staffing, our physician needs, all the things that we've talked about earlier. And next slide.
I think
that's it. Okay, all right.
Okay, Vice Chair Hayes, members of the committee, thank you so much for this opportunity. I know it's been a long day. I will try to keep my comments to about 5 minutes today. My name is Neil Vabakar, and I too have the privilege of serving as one of the ED Wait Time Commissioners. And while I'm not here in that official capacity of the Wait Time Commission, I do come before you as the Associate Chief Clinical Officer for the University of Maryland Medical System, as an emergency medicine physician, and as a Marylander whose family and friends rely on our healthcare system to deliver timely, high-quality care. As we come out of one of the most severe flu seasons in recent memory, This winter demonstrated both the extraordinary dedication of our healthcare workforce and the limits of our healthcare system when capacity is strained. I appreciate the opportunity today to share both the progress that has been made and the work that still lies ahead. National research and the ED Wait Time Commission's interim report demonstrate that the emergency department itself is not the bottleneck. When patients cannot move out of the hospital, they cannot move through the emergency department. The result is boarding, admitted patients waiting in the ED for inpatient beds, the most significant driver of prolonged ED wait times. Hospitals across the state have implemented numerous best practices to improve throughput and efficiency. These include rapid assessment zones in the emergency department, earlier bed availability with the creation of discharge lobbies, the use of predictive analytics and artificial intelligence to improve length of stay management, executive-led patient flow governance with real-time data transparency, interdisciplinary care, transition rounds that allow for discharge planning on day one of hospitalization, standardized observation pathways, and daily operational huddles to address bottlenecks. These efforts have produced meaningful results across the University of Maryland medical system. We have seen a 25% reduction in the number of patients who leave the emergency department without being seen. In addition, the average time from emergency department arrival to discharge has decreased by 15 minutes per patient, with some hospitals achieving improvements of 30 to 60 minutes. Our emergency departments across UMS see approximately 500,000 patients per year. So these saved minutes add up fast and translate to more patients being cared for sooner. And while this progress is important, the boarding crisis demonstrates the overwhelming impact it can have on ED operations. Although many factors contribute to boarding, the data clearly points to 3 areas that require our focus. First, as you've heard, inpatient bed capacity. As our population ages, the care needs that will become more complex and hospital stays will be longer. The number of Americans aged 65 and older is projected to grow from approximately 60 million today to more than 80 million by 2050. At the same time, hospitalizations in the U.S. are projected to increase from 36 million a year to 40 million per year over the next decade. Maryland enters this period with one of the lowest numbers of hospital beds per capita in the nation, ranking 47th overall. This mismatch between growing demand and limited inpatient capacity results in persistently high occupancy levels and ED boarding. In recognition of this challenge, the ED Wait Time Commission is actively analyzing multiple data sets to better understand current and future inpatient bed capacity across the state. The second major contributor to constraining inpatient capacity is patients with prolonged hospital stays. Hospitals are responsible not only for treating a patient's medical condition, but also for ensuring a safe and appropriate discharge. Increasingly, non-medical factors such as social, legal, and behavioral health challenges drive extraordinarily long lengths of stay. Multiple studies demonstrate that patients hospitalized longer than 21 to 30 days represent only 2 to 4% of admissions, yet they account for 14 to 27% of all hospital days. These prolonged stays are often driven by guardianship delays, behavioral health placement challenges, particularly for the pediatric and elderly, housing instability, and unmet social determinants of health. Importantly, these patients are medically stable. However, their non-clinical challenges force hospitals to function as long-term care settings for needs they were never designed to meet. This significantly reduces effective inpatient capacity and contributes directly to ED boarding. Finally, transitions to post-acute care, as you've heard today, represent one of the most significant barriers to efficient flow. Internal analyses show that the length of stay for patients awaiting post-acute care placement is one of the single largest drivers of ED boarding, particularly impacting the ED1 metric, the time from ED arrival to an inpatient bed. It is also the #1 cause of avoidable days in the hospital. The ED Wait Time Commission has identified several contributing factors, including high occupancy rates and staffing shortages in post-acute care facilities, payer authorization delays, insurance denials, and regional imbalances in post-acute care bed availability. Furthermore, statewide data shows that the length of stay, as you saw earlier, for home discharges is actually better than national standards, while the length of stay for post-acute discharges is worse than the national standard. Although fewer patients are discharged to post-acute, these patients often experience hospital stays 2 to 3 times longer than those discharged home, frequently due to delays unrelated to their clinical condition. Improving transitions to post-acute care represents one of the most effective opportunities to create inpatient bed capacity and meaningfully reduce ED wait times. So to close, we are, I believe, at an important inflection point in our efforts to improve emergency department wait times. Meaningful progress has been made through operational changes and innovation. However, further improvement will require addressing the capacity constraints that exist beyond the emergency departments itself. I commend this committee and the ED Wait Time Commission for elevating this issue and focusing it on the right root causes. I look forward to our continued collaboration in developing practical, statewide solutions to these complex but solvable challenges on behalf of the patients and the communities that we serve. Thank you.
Thank you, and thank you all so much for your testimony here today. Senator Lamb.
Thank you, Mr. Vice Chair. Wanted to just kind of extend our appreciation to Dr. Vibhakar and also Dr. Ahmed for, I've had the opportunity to tour both facilities at BWMC, appreciated kind of the walkthrough of how you've been able to kind of streamline that process. I think that really helps and hopefully can be able to be, and I'm sure you're working on promulgating this across the system too. I think you've moved into a system role yourself. So a lot being done there. And then also with our behavioral health unit expansion of the ED, I think all of that is great to be able to have that support from our local government and also from us to be able to see that Howard County Medical Center. I guess the two separate questions for each of you, I guess when it comes to, and this may be for Dr. Vibhakar first, the certificate of need, you heard me touch on that with the last panel as well. From your perspective at a system level, where you're able to see across multiple different hospitals across the system, what's your sense of how difficult the certificate of need process is now making challenges for our ED throughput and efficiency process here?
While I appreciate the senator's question and direction, I'm going to ask one of you all decide who's the best person to answer that question. Thank you so very much.
So thank you for the question. What I would say is right now, what we identified is the need for bed capacity. That can be handled in a couple of different ways. The certificate of need, if there's a physical bed need, is one way to do that. But the other ways are some of the things that we've already talked about. How can we more efficiently bring patients through the beds that currently exist in our organizations? And so I'd say it would be a multi-pronged solution, depending on what each member organization, which hospital has what needs. If you are already constrained physically, then that physical expansion will be an important conversation. But if you have the physical beds and we still need the ability to staff it, or we have an opportunity to gain efficiencies through some improvements and innovation, that's another way for us to create that bed capacity.
Okay. And last question for Dr. Ahmed, the behavioral health piece. It's something that we've seen in Howard County General. What's your sense of how much we need to address the behavioral health needs across the state where, at least from my opinion, I think we're probably falling short of some of the capacity needs that we need to be able to address what you're seeing in the ED?
Yeah, thanks for the question. I think you're correct. I think the total capacity for inpatient psych is not where it needs to be. I think that's one of the reasons that the wait time is so long for a patient being assessed. I think the other thing is, do patients really have access to primary behavioral health? And how are they getting that on the outside? Because right now, if you have $250 an hour to pay, you can get that. But if you don't, you're out of luck and you may not get that for months. And that is a challenge. And so being able to address those issues is not necessarily within the scope of what HSCRC is particularly doing or the hospitals are doing, but it's a very important one nonetheless. And I think it's going to be helpful. I think as a society, we're just going to keep seeing these issues, but addressing it at the end of the acute spectrum where you're seeing us in the hospital, that's probably not the best way to do it, but that's what we have to do today.
All right. Thank you for your patience. Thanks for sticking around.
Thank you, Senator. Delegate Hutchinson.
First of all, thank you for staying here all day. I know it's been a long day, but this is actually pretty enlightening to see that. And Dr. Ahmed from Howard County, you're putting in some nice capital improvements. I look forward to seeing the results of how that changes next year. So, so I wasn't sure they asked this question to the first panel or this panel. So, Andrew, I think you're the one. So, over the last 3 years, I have asked various healthcare professionals here in Annapolis, does the waiver have any effect on ED wait times? And they all swore me to secrecy to not disclose who they were. They all shook their head yes. Assuming you agree with that, do you think that going to the HEAD model will help in any way?
Well, I think you ask a good question, but it is one that I think we wrestle with as a state, and hospitals wrestle with it in conjunction with our regulators, particularly with the HSCRC. I think, as you heard, there are many headwinds that hospitals are facing, and certainly, I think when the folks nod their head yes, they're probably in their mind thinking about this capacity issue. because that has been a challenge for many hospitals over the years. Where I think we see ourselves moving, and where I'm optimistic, even within the work of the ED Wait Times Commission, is that we can first get an understanding of where's the need, because I don't believe that the need is universal across the state. It's likely a regional issue, what the capacity issues are. And then collectively as a state, how do we move forward and address that under the model in a way that kind of ensures stability for all of the hospitals? Because in this model, we are all in it together, and so that's part of the challenge. So I think that, in conjunction with many of the challenges, addressing the inpatient capacity issue remains, but it's one that I see us leaning more into as a state.
Thank you. Thanks for being here today.
Thank you.
Delegate Raleigh.
Thank you, Mr. Chair. So we heard from both panels that one of the, ideas or tools that we can use in the toolbox is to hire more PCPs. And that would keep the people out of the ED weight room. So, but that is a challenge in itself, which I'm sure you are aware of. And people avoid going to the PCPs, first of all, because there's very few of them. And I don't know what the reason is. Some people say it's a reason because they don't get paid enough for their salary, and they don't get enough reimbursement from the insurance companies, multiple different reasons. So that's part of the challenge. And the wait time to go to see a PCP, because there's so few of them, I guess. It's up to like 3-4 months, and especially if you want to see a specialist. So people that are, in need of health care and they have to wait 3 months, they're not going to do that. So that's one of the reasons why they probably go to the hospital. So we know this is an issue, and I heard from the previous panel that that's one of the things they're going to look at to make that a tool to, decrease the ED wait time. But I, physically, from what I hear, don't see that that's a real solution at this point. I do know I'm fortunate to live in Harford County, and we have a great hospital, and it's part of the system. So I'm going to ask Dr. Vibhacker, is that how you say it, or however? Because I know that we in Harford County have made some progress in how we went out and actually, garnered new PCPs. Can you maybe give the committee an idea how you went about that and the challenges that you may still have?
Sure. Thank you for the question. Primary care is of an utmost importance in our recruitment for all the reasons that you mentioned. We were fortunate in Upper Chesapeake, as you mentioned, to be able to have a strong primary care presence, and that's a very close-knit community that serves its own community, which I think is an advantage to that area. And we're taking lessons learned from across our system to meet physicians where they are. In terms of not just reimbursement in their salaries, but also what they're looking for in their job, in their community, in serving their patients. And we believe that by paying competitive salaries, we're able to recruit in a way that's going to accomplish the goals that you're trying to accomplish. Because it's not just about the lower acuity patients that need to get seen, but it's also to avoid them becoming higher acuity patients. If someone comes into our emergency department with a low acuity issue, I'm not too worried about that. That's not going to clog up our emergency departments. But what will is if that same patient is coming in because they didn't get their hypertension treated or their congestive heart failure treated, and therefore they're coming to us as a last resort. The other reason why it's important is on the back end. Because once we discharge a patient from the hospital, we need to ensure that they're getting seen within 48, 72 hours, hopefully, as we know that the risk of readmission is quite high if they don't have that follow-up care. And so we're doing several things at the system level to recruit for primary care physicians and think about the future and where the needs are going to be, and believe that we can be successful based on everything we've learned from our other organizations within the system.
All right, well, thank you. Mr. Chair, just a follow-up question real quick. So I know years ago when you went to the hospital, whether it was ER or from inpatient to outpatient, and like you said, there's several hours, 48 hours, 24 hours, whatever it is, to follow up with your primary care doctor. I know I've had some constituents to say, well, they tell me, the hospital tells me I have to follow up within 48 hours, but then I can't get the appointment from the PCP in 48 hours. So has that changed? Like, if you have that doc from the hospital saying you need to go see your PCP 48 hours and they fit you in, or is that still an issue that they're not fitting in and they come back and call you all? Somewhere along the line that changed and they can't get in. Is that still a problem?
Lots of hospitals inside the University of Maryland system and outside have set up what we call bridge clinics, where these are clinics that are set up specifically to accommodate patients who are being discharged from the hospital. So they may have a primary care physician, but in order to bridge them to that primary care physician, if they can't see them, we'll be able to see them in the next 48, 72 hours to get them close follow-up. I'd also say we're going to leverage technology, and so to the extent that we can utilize telemedicine as well to make sure that people are at least getting a touch point at home to make sure that they understand their medications, make sure they understand when they need to follow up, make sure they don't have any other questions as well.
Okay, thank you. Excellent. Thank you so much. Thank you, Madam Chair. Or Mr.
That's okay. Are there any additional questions from my colleagues? Seeing none, I just want to say thank you on behalf of Chair Bidel, Chair Bagwell, Vice Chair Cullison, Bagwell, Vice Chair Cullison, all of us on Senate Finance, as well as the House Health Committee. On the quote of former Chair of Senate Finance, you all have made us much smarter, and thank you for your time and patience to everyone who's participated here today. We have a lot to do this legislative session, but I think today you all have started us with a good foundation as we go ahead, and we appreciate your time and your patience. So with that, we will call this joint hearing of both committees to a conclusion. Thank you so very much.